Terrific. Well, good morning, everyone. We're going to go ahead and call this HHS committee session to order. And we have a chock-full agenda this morning, and we are first going to begin our discussion by conducting a review of our nursing homes. Our nursing homes have been disproportionately impacted, as well as all congregate living settings since the beginning of the pandemic. It has been painful, it has been challenging both for the staff of these facilities, the patients and clients of these facilities, and of the family members who have not been able to connect to their loved ones in a way that they and all of us would have preferred or liked. This issue is complicated because a lot of the regulatory issues cross over into our state colleagues. But I want to acknowledge and thank our Department of Health and Human Services, who from the beginning of the pandemic have done everything they can to put all measures in place to try and extend PPE, to try and provide additional support to these nursing facilities through testing, and create a systemic approach that hopefully will help ensure that we prevent the kind of tragedy that we saw at the beginning of the pandemic. It has been challenging, to say the least, and emotional on so many different levels, but we thought it was important to have a discussion, and we're going to do this in two parts. The first is today and this morning to talk specifically about Montgomery County's response and all those areas in which we manage and control. There will be a second session in which we will invite our state partners, because there is, as I said, important regulatory component to this at the state level as well, that we will be doing before full council, because the nursing home issue has impacted our entire county, and this has garnered an understandable interest in all of our colleagues on the council, who have all been dealing with this either personally and professionally, but also clearly in response to constituent and emotional constituent questions and concerns that have come in. So with that, we have a very impressive group of leaders this morning who will be part of this panel. I now ask that you turn your videos on if you haven't already. We will be joined by Dr. Raymond Crowell, the Director of HHS, Dr. Travis Gales, our Chief Public Health Officer, Dr. Odile Brunetto, Chief of Aging and Disability Services, Dr. James Bridgers, our Deputy Health Officer, Clark Beal, the Senior Administrator and Licensure and Regulatory of Division Services at DHHS, Enrico Lachica, the Clinical Nurse Administrator, Licensure and Regulatory Division of Services at DHHS, and Eileen Bennett, the Program Supervisor for the Long-Term Care Ombudsman Program. So with that, I turn it over to Linda McMillan, who has done, as always, an outstanding job in not just preparing this packet, but also working deeply with all of these and so many more providers on the policy end, on the programming end, and has been just a tremendous source of strength through all of this. So Linda, if you can kind of give us a little bit of overview and context on the packet, that would be great.
So I really want to thank the Department of Health and Human Services for what you will find to be a really, really thorough presentation. Mr. Lachicha has really just been so helpful in going through this with us. In any circumstance, the council having a good understanding of the county's and the state's role in the oversight of nursing homes is important, because some of our most vulnerable and frail residents are always in nursing homes. And so we've always had a robust ombudsman program, which Dr. Brunetto's division will talk about as well. But there's a public health role, there's an aging and disability role. There needs to be ways for family, and this is becoming even more important, ways for family or friends who are worried about their loved ones who are in nursing homes to be able to find out how they can report concerns, how they can get responses. And then, of course, the presentation will specifically talk about COVID and how the rules and regulations have played out during COVID. So I think you have a really thorough presentation. As Councilmember Albornoz said, the goal of today is to give the committee a really good baseline get your questions, get your follow-up, and then we'll be working with the council president to structure a full council session later where we would also invite representatives of the state so that you can discuss the state's role directly with them. And with that, I would turn it over to DHHS for however they want to make their opening comments.
Thanks, Lyndon. Really quick, before turning it over to DHHS, just a time check. As I said at the beginning of the presentation, we have a very tight timeline. We will also be getting briefings this morning from our African American Health Program, as well as our Latino Health Initiative, on the very important projects that we have moved forward in response to the pandemic. And we will also have a joint education and culture and HHS session later this morning to talk about a special appropriation. We're going to try to get all that in before 12:30 today. And so there's a lot there. So let's aim to have this conversation end between 10 and 10:15. And then if it needs to go longer, we'll see what we can do, but just to put that in folks' mind as they give their presentation. So with that, turning it over to DHHS.
Good morning, everyone. Thank you for the opportunity to talk about a topic that our team spends a good amount of time pre-COVID, during COVID, and post-COVID, in the interest of time and to provide the platform for them to highlight the work that they're doing and continuing to do. The only remarks I would say is to emphasize what has already been said about our value in protecting our most vulnerable residents. We continue to work with our colleagues at the state level to ensure that they are getting the appropriate updates and that we are tapping into the resources that they have available to us to help augment the work that we're doing. As this continues to move forward, as was evidenced in the packet, we were hit very hard with our nursing home population early on in the pandemic, both in terms of cases as well as fatalities. I will say that we did take some proactive steps that preempted the work of the state in some cases in creating local go teams to provide technical assistance and support, which continues through, and I know that Enrico will share more about that. And we have also been working with our colleagues at the GW around nursing home surveillance information to be able to track cases more closely and quickly, to be able to respond more proactively to try to curb the number of cases. We've provided significant amounts of PPE support as well to hopefully mitigate transmission. And we have been very proactive in terms of integrating the guidance of the state, whether it's around visitation policies or testing policies, to ensure that those practices are adhered to. The last piece I want to just mention briefly and turn the floor over to Enrico is that our nursing homes, as part of the next phase of COVID management with vaccine dissemination, all of the nursing homes within the county have signed up for the partnership program with pharmacies to directly distribute vaccines to those facilities and to assist them in administering those vaccines once they become available, which we hope the first set will become available within the next several weeks. Unless there's any other comments from Dr. Bridgers, I'll pivot to Enrico to begin the presentation. I'm happy to answer any questions you all may have.
Good morning, and then from me, Dr. Gales. Thank you.
Thanks, Dr. Gales. Let me open the PowerPoint presentation. Can everyone see my screen? Thank you. Good morning, everyone. My name's Enrico Lachica, and I'm the Clinical Nurse Administrator for the Healthcare Facilities Program at the Office of Licensure and Regulatory Services. I'll be giving an overview of the program and the county's COVID-19 response in nursing homes and assisted living facilities. Joining me today on the presentation will be Dr. Odile Brunetto, who's the Chief of Aging and Disability Services. The mission statement of the department is to ensure and promote the health and safety of vulnerable adults residing in long-term care facilities within Montgomery County. Montgomery County has one of the highest concentrations of long-term care facilities in Maryland, serving approximately 9,000 residents. We have 34 nursing homes in the county, 37 large assisted living facilities, which are licensed for 17 or more beds, and 233 small group homes or small assisted living facilities, which are licensed for 3 to 16 beds. The county department, this unit consists of nurse surveyors or inspectors who are federally certified to conduct complex inspections and investigations of nursing homes. Nurse surveyors determine if nursing homes are in compliance with federal, state, and county laws and regulations in order to be licensed and eligible to receive Medicare and Medicaid funds. Healthcare facility inspections are unannounced and conducted on and off site. So the county department acts as an extension of the state agency Office of Healthcare Quality, or OHCQ. OHCQ is the agency within the Maryland Department of Health charged with monitoring the quality of care in Maryland's healthcare facilities and community-based programs. In Montgomery County, OHCQ conducts inspections at all of the assisted living facilities. In addition, OHCQ offers technical assistance and administrative oversight to the county department. This includes preparing and issuing survey findings to facilities, coordinating legal enforcement actions to be taken, coordinating administrative appeal hearings, and offering ongoing training to the county department. So pre-pandemic, the nurse surveyor duties included review of nursing home surveys and complaints, touring facilities to get an overview of resident staff and physical environment, review of resident records, evaluation and observation of resident quality of care, and interviews of resident staff, families, and resident council members. In addition, nurse surveyor responsibilities also included conducting complaint investigations, investigating alleged abuse and neglect cases, and participating in bioterrorism and emergency preparedness planning and operations. So during the COVID-19 pandemic, the nurse surveyors have assumed additional responsibilities to assist with the COVID-19 response. This included providing technical assistance to facilities with infection control practices, coordinating local and state action team visits, communicating facility PPE and testing needs to emergency preparedness agencies, and disseminating the latest guidance from state and federal agencies. In addition, the nurse surveyors have been conducting on-site focused infection control surveys to assess facility compliance with infection control regulations. So when a nursing home is cited for a serious health or fire safety deficiency or fails to correct a citation for an extended period of time, this can result in a penalty. Penalties can be a monetary fine against the nursing home or a denial of payment from Medicare. The penalties are based on the scope and severity of the deficiency and are determined by CMS and Office of Healthcare Quality. Survey results and any federal civil monetary penalties within the last 3 years are publicly available and published on the Medicare.gov website and the Nursing Home's Medicare.gov profile. These federal civil monetary penalties can range to up to $10,000 per day for a harm deficiency, or payment denial of resident stays, or a withdrawal of state approval of the Nurse Aid Training and Competency Evaluation Program. Next, I'll turn it over to Dr. Brunetto to discuss the Ombudsman Program.
Thank you so very much. Enrico, can you move the slides? Okay, thank you so much. So good morning, everyone. Thank you again for welcoming us to be part of this presentation to the HHS committee. The Long-Term Care Ombudsman Program is a federal mandate until the Older Americans Act, and it is a state administered program and locally provided through the Area Agency on Aging. And this program has been in place since the late 70s. In Montgomery County, we have operated this program now for 41 years. As a matter of fact, 2 days ago, we celebrated our 41st anniversary, and the program is provided in collaboration with multiple fantastic volunteers. Volunteers and staff need to be certified by the state ombudsman, and they are trying accordingly to the regulations. I am very delighted to let you know that our manager of the program is here on the line this morning with us. Her name is Eileen Bennett. The program has had a national reputation of being a leader. Eileen and her staff and the volunteers have been at the White House. They have gone on Capitol Hill to provide testimony. So I think you are going to enjoy Eileen's presentation.
So thank you for the opportunity to speak this morning. Enrico, if you'll continue to go through the slides, I probably might deviate just a little bit from what's on the slide itself, just to provide some integrated information and not necessarily rely on all of the statistics. So can I get you to advance? Thank you. So really important, I do want to just say that we are the voice of the residents. Everybody else is focused on the facility and the operations and the mechanics of providing care, getting care, distributing care, reviewing care, indicating deficiencies where they exist. The unique role of the Ombudsman is resolving individual complaints and issues at the resident's discretion. So if the resident is asking the Ombudsman to help them with information and empowering the resident to take action on their own behalf, that is our first goal. We also do systemic advocacy through laws and regulations. Advance, please. We include volunteers, and within that, I do have some statistics that we pulled, and the big difference is the COVID. We are a program who had been on site in all of those facilities that Enrico mentioned, the 34 nursing homes, the 233 assisted living on a regular basis. We do not have to go because it's a complaint or there's for an annual review. We go regularly. Regularly is defined as at least quarterly. In nursing homes, we would go at least weekly, where we have volunteers. And our presence was monthly by staff if we didn't have volunteers. And in every one of those senior assisted living, the small group homes are quarterly, and the large assisted living is at least monthly, but weekly where there are volunteers. Then came March, and you can see how that has made a difference in our statistics themselves. How we've had to operate is remotely. We have not been able to re-enter yet into the facilities for one-to-one visitation. And you can see the difference. We're running on a federal fiscal year, just so that you know. Our federal fiscal year ends September 30th. So you'll see that our complaints are different. Our consultations, which is what we called them last year, this year we call the same action, information and assistance to staff and individuals has gone way up. Our complaints have actually gone down, and we know that that is because many of our complaints would come to our attention when we were on site, when we were visiting, when residents had a chance to talk with us individually as we were in the facilities. Can you advance, please, Enrico? Again, we're talking about this. We've made 6 visits in since March, just to let you know that, as compared to a little over 1,500 visits. Is what we had done in from October 1st of our federal fiscal year to March, and then since March we've done 6 visits in person. Last year we did 3,200, a little more than 3,200 visits by Ombudsman, and that includes staff and volunteers. It also makes a difference in what our volunteers are doing. Our volunteers are not necessarily giving us as many hours because they're not going to the facilities themselves. They're doing things remotely, virtually, on the phone, et cetera, et cetera. And 6 visits is what we have done. So I do want to be clear about that. We hope to be able to get back in person, but we have not been able to do that yet. The result we know from residents that call us is isolation. They constantly are telling us they want to have everybody come and visit them. And so we are the gatekeeper of the information that says how you might get a visit through compassionate care if you have somebody who fits that category, and meeting all of the levels that have to be addressed if somebody has a family member that's going to come in on compassionate care or outdoor visitation, which we now know the weather is not cooperative, et cetera, et cetera. So can you advance, please? Here we go. Can you advance? So they're not advancing. Under the Older Americans Act, one of our mandates is to, we actually have a law. This is so exciting. We have a law that says we recruit and train and supervise volunteers. We are so fortunate to have that law that says that we are supposed to do that. And they are an integral part of our program. And I really want to just reiterate over and over and over again that we work as representatives for residents, and we are directed by the resident on what they want us to do. We've had a lot more obvious connections with families since the COVID started for us in March, because families want to get in and visit with their loved ones. We honestly do a lot of education of individuals for self-empowerment. We have intervened with cases that are complaints. We are not enforcement, and that's the difference between us and licensing and regulatory. We do not have the ability to impose fines. We do not have we're not in law enforcement, so we can't bring criminal activities. We have to engage a resident's permission to access those services if they want to go that route. Most of the time, residents don't want to take an action that is punitive to their caregivers. They just want good care. They just want the Ombudsman to help them be able to get their point across to their caregivers of what they need. Can you go ahead, Enrico? So we have, just to understand our coordination with our state ombudsman, we have had 2 to 3 meetings a week with our state ombudsman to go over each and every one of those things that Dr. Gales is always talking about, and trying to keep up with where things are. It is our advocacy effort during the pandemic at this point being virtual and by telephone. We do like to get together. That's what ombudsmen do. That's why residents like us, because we get together with them and we participate in their daily lives to improve their quality of life. We've just been doing it remotely. Can you move ahead? So I will want to just underscore that the Administration for Community Living, which is our federal oversight, has defined in the past our regular presence as being at least quarterly. They are not changing that definition. I will tell you that just concerns us in a reporting year, that when we haven't gone in, we're going to have big zeros. So I'm just warning you that our reports are going to have a skewed view of what ombudsmen have been doing, but virtual visits don't count under regular presence, so we haven't had in-person visitations. Our date was March 13th. That's when we stopped going. CMS decided ombudsman can't go. In September 17th, you can go ahead, Enrico. On September 17th, CMS did address ombudsman being able to visit. And so the state ombudsman has been working with us on being able to prepare ourselves for re-entry, including local permission, whether our rates are at a level where it will be a good idea for ombudsmen to begin visitation. These are the things we've been doing. I've talked about them as we've been talking. I do want to share that we've had some in-service education ongoing with the nursing homes and the assisted living. They have been successful in having virtual presentations to actually probably get more cooperation and more participation from the facilities than we have when we were doing the in-person change of shift, 10-minute kind of presentations. And they're more interested now in actually hearing how they might improve quality of life as well as quality of care. Can you move ahead, Enrico? I was asked to give a couple of examples of some of the things that we've done since COVID, so I did want to share some what we call success stories that resulted actually from our visitation. We have a resident that has ALS in one of our nursing homes who was having tremendous difficulties in getting the nursing home to allow the time necessary for him to be able to communicate. He has a assistive device. He is at the point in his life where he uses his eyes to run his computer assisted device to communicate. And they were not allowing him the opportunity to eat in a manner that he would be able to finish his food. And we were able to meet with him outside, create a care plan virtually, working with a family member to try and get that family member in for compassionate care. And I happen to know this is one that License and Regulatory also looked at once the Ombudsman brought it to their attention, and they were on site for review. We also had a married couple who was living in a Christian-oriented facility, but practiced religious rituals that were not necessarily Christian, and their faith was a little different than the norm of the population there. And through visitation, outdoor again, the Ombudsman was able to work with the individuals to get the religious rites timely within the time period that would be appropriate for them to practice their faith. We also, again, spend a lot of time on assisted living, and we have entered into some on-site visitation for emergency relocation. And I want to shock you. And I say this because I know we're talking about nursing homes where there's a lot of caregivers, and even when people call out, there's more people to provide care. We went to a small assisted living group home where there was no caregiver on site. The only person that was there was a resident. Resident answered the door for OHCQ surveyor who was there for licensing review, not for any complaints, and immediate jeopardy was called, and Ombudsman had to go in to help relocate that resident. But we have too many times that the Ombudsman throughout a year, through their unannounced visits, would discover that there are no qualified caregivers in those homes with the residents being there by themselves, even though they are required to have caregivers on site. In this particular situation, this owner is a registered nurse and was at their other job. So I just point that out because if that didn't shock you, I have lots of other stories that do, but I don't need to share them today. Can you go ahead, Enrico? I just wanted to point out again, we are doing telework activities. We have Resident Rights Month every October. But we've been sending information and materials to the activities directors for improving quality of life during the isolation periods. We've had some very active family council meetings where there are family councils that exist. They want to know more and more about how they can empower themselves to get information, to get their residents to be on the top of the list for consideration. Dr. Gales, I'll just throw this to you one time, that says they want to be heard about getting the vaccines because they're hearing nursing homes only in the news. And we've done, again, the systemic advocacy and speaking at every level possible, as well as continuing education. Can you move ahead? Go ahead. I've already talked about this. So who are we? I just want to tell you we're a staff of 8 members. One is me. I'm administrative as well as on-site working cases. I have a office services coordinator who does the logistics behind the scenes, as all of you know how important they are to each of us. And I have 5.5 staff members that are in the that have field duties, I should say, and that help to supervise the volunteers. Right now we have 33 active volunteers. We've been as high as 75 in the past. The last several years, we've run around 50. Yes, COVID has affected us in being able to do some recruitment. So we're losing people through attrition who have been deciding that this is not what they want to continue to do in a hands-off kind of contact. But we also are not at the point where we can bring people in because we're not doing visitations. So I will tell you, most of our volunteers are 70 and above. So they hit that risk factor of if they were to go into facilities, what risk are they bringing upon themselves? I will also tell you, we have 80 and 90-year-olds that do regular visitation pre-COVID. So I do want to share that. We will have a challenge as we do a reentry. And some are saying until widespread vaccinations are available, they're not going to do on-site visits. And we have several that have agreed that they would love to do outdoor visits as the facilities can figure out a way to make residents comfortable in the cold. We'll bundle up, but I don't know about those residents in the cold. Go ahead, Enrico. Just talked about that. We continue to collaborate. I'll just tell you, we're Enrico and I have become great friends since March 13th, even though we certainly were colleagues before that and worked together. But I will tell you, licensing and regulatory and ombudsman are connecting probably at least 5 days a week and multiple times in a day, sometimes to discuss the individual issues that are arising. We also are working with Adult Protective Services and our colleagues in the Medicaid waiver, as well as adult foster care and guardianship, because they all have residents that are in long-term care settings. And again, I know we're focused on nursing homes today, but there is another component that's bigger in the long-term care system than just nursing homes. Go ahead. And if you need to find us, this is our main number. And of course, anybody can contact me directly. Thank you so much for letting me speak today.
Thank you for the overview. Okay. So next up, sorry, I'm hearing some background noise. Next, we'll discuss the county COVID-19 response in the long-term care setting. So attached is a chart of the number of positive cases reported in county nursing homes and assisted living facilities throughout the pandemic. As you can see, there was a significant increase in cases in mid-April to mid-June. This leveled off in the summer months. However, you can see the cases have fluctuated during the fall months. So COVID-19 is a significant source of deaths in the long-term care facilities. As you can see, the sharp increase in deaths in mid-April to June corresponded with the sharp increases in cases in the facilities. And some of our most vulnerable residents live in these settings, and it's a priority to protect those individuals. So the Maryland Department of Health has imposed rigorous testing requirements on long-term care facilities across the state. Facilities are required to test staff twice a week and residents once a week until further notice. This has aided in identifying cases early on and has allowed facilities to isolate affected staff and residents and limit the transmission of the virus in the facilities. The Office of Inspector General at the state level monitors facility compliance with these testing requirements. It's pretty important to note that if a facility has one new onset case in the last 14 days, they are considered an outbreak status and posted on the Maryland Department of Health website. Testing requirements at assisted living facilities vary slightly from the nursing homes. Testing frequency of the staff is dependent on the county positivity rate and licensed bed capacity. So for facilities licensed for 50 or more beds, they are required to test staff monthly if the county positivity rate is less than 5%, weekly if the county positivity rate is between 5 and 10%, and biweekly if the county positivity rate is greater than 10%. If any assisted living facility has had a new onset case within the last 14 days, They must test staff and residents weekly until there have been no new cases for 14 days. So currently, the county positivity rate has been between 5 and 10%. So assisted living facilities are testing staff weekly at this time. Next, I'll talk about how the county and state monitor facility cases. So each facility is assigned a nurse outbreak investigator from both the state and local health departments. Facilities in outbreak status must provide a daily report to the investigators regarding new cases, pending test results, and any symptomatic staff or residents. These outbreak investigators or the facilities themselves may request a virtual infection control assessment with the facility leadership. Additionally, all laboratories in Maryland are required to report positive cases to the COVID-linked database. This database is monitored daily by state and local health department officials. So what does this mean? If a facility has had 5 or more cases in a week, with at least 3 of those cases being residents, they are referred to a state technical assistance team for the infection control assessment on site. So these technical assistant teams conduct on-site assessments and provide infection control recommendations. If there are significant findings, facilities are referred to a certified infection control preventionist. So these certified infection control preventionists also conduct on-site assessments and provide targeted recommendations to the facilities. If there continues to be ongoing significant findings found on the certified infection control preventionist visit, facility is referred to OHCQ and the county licensure and regulatory department for a regulatory inspection. Additionally, outbreak investigators from both the state and local health departments may require facilities to suspend new admissions and visitation in response to any ongoing transmission concerns. So during the early stages of the pandemic, visitor restrictions were placed on nursing homes and modified visitation was put into place in July. So currently, per CMS guidelines, outdoor visitation is preferred whenever practicable. Facilities must create safe outdoor spaces for visitation and limit the number and size of visits occurring simultaneously to support safe infection prevention actions. However, facilities may accommodate indoor visitation if they've had no new onset COVID-19 cases in the last 14 days and the facility is not currently conducting outbreak testing. However, if the county positivity rate exceeds 10%, visitation should be suspended except for compassionate care situations, which are usually end-of-life situations, or if a resident has had severe disruption of functioning and requires a family member or representative. Also, on September 24th, the Maryland Department of Health issued guidance regarding access to support for patients with disabilities in healthcare settings. Patients with disabilities, which is defined as a patient with a physical or mental impairment that substantially limits one or more activities of an individual. These patients may designate 2 support persons to assist them with decision-making and care. Facilities must allow access of the support persons to their residents regardless of outbreak status. The facilities must provide the appropriate PPE and instructions on proper usage to these support persons. Additionally, communal dining and group activities for the residents were restricted at the start of the pandemic. At present, this has been opened up again, and communal dining and group activities may occur for residents who are not on observation or isolation for COVID-19. And the facility must maintain social distancing among residents, ensure that appropriate hand hygiene is being performed, and face coverings are worn by residents when outside of their rooms. Next, I'll talk a little bit about facility PPE needs during the pandemic and how the county has supported facilities with these needs. During the first surge of cases in March to May, the demand for PPE was significant and the supply chains were disrupted. Facilities had to resort to reusing PPE under crisis and capacity strategies outlined by the CDC. From March to August, the county was distributing PPE to facilities routinely and upon request. As supply chains started to become restored in September, the county scaled back on PPE allocations as facilities were able to procure supplies independently, and the state imposed additional requirements for local health departments to distribute PPE to facilities. So the nursing homes and long-term care facilities represent the county's largest number of at-risk congregate care residents, and they have experienced the greatest impact from facility-related COVID-19 outbreaks. So as such, they've been given county priority to ensure appropriate levels of emergency PPE supply. To date, 64% of all county N95 respirators has been distributed to the nursing homes, 92% of all KN95 masks, 42% of all surgical masks, 73% of all gloves, and 74% of all face shields and eye protection. So when determining PPE allocations to healthcare facilities, county HHS must consider the following criteria. The availability of the emergency stockpile, because the county HHS is also responsible for supplementing PPE supplies for other county healthcare agencies and facilities and providers. Additionally, the availability through existing supply chains, the number of skilled nursing beds each facility is licensed for, the outbreak status of individual facilities, additional N95 and isolation gowns are provided to facilities who are experiencing ongoing outbreaks, and the facility's desire to transition to a more conventional usage of PPE. So on this slide are the key milestones for PPE distribution for long-term care facilities. Back in March, the county HHS started to begin distribution of PPE from the local public health stockpile. In April, the Maryland Department of Health established an emergency medical management response process for requesting PPE from local and state health departments. This online request process was implemented in mid-April, and to date, 1,121 online requests have been received. In June, the county HHS provided a significant push of PPE resources to facilities and provided updated guidance on transitioning from crisis or contingency usage of PPE to more conventional strategies. In September, the state published updated guidance on distribution of PPE resources to facilities and placed additional requirements before the local health department may release supplies. In October, the Maryland Department of Health published additional guidance on the requirement that facilities must maintain 30 and 60-day private stockpiles of PPE by certain deadlines. Additionally, the county HHS was also able to provide fit testing supplies to facilities who identified a need to fit test their staff for N95 masks. So starting on September 29th, the state placed additional requirements on local health departments for distribution of PPE. Those requirements are that all the partner facilities must exhaust all supply chain possibilities prior to going to the local health department or state health department. Partner facilities are not charging a PPE fee when receiving PPE from the state or local health departments or otherwise profiting from the supplied PPE. Nursing homes and long-term care facilities that receive direct funding for PPE from the federal government are using those funds first before going to the local health department. and facilities must attest that they are utilizing the PPE conservation measures as defined by the CDC. So on October 27th, the Maryland Department of Health issued a new directive towards nursing homes requiring all facilities to maintain a 30-day private stockpile of PPE by November 30th and a 60-day private stockpile of PPE by January 31st. The purpose of this private stockpile is to ensure that nursing homes have the capability to respond to outbreak situations and maintain flexibility prior to state and local assistance. The county has developed a significant stockpile of emergency PPE to further backstop county agencies and healthcare partners during any further supply chain stoppages. Facilities with urgent PPE needs that meet state requirements can submit PPE requests with county HHS at the link posted below on this slide. So in addition to PPE support, the county has strongly recommended that long-term care facilities vaccinate residents and staff members during the influenza season. Per state requirements, facilities must offer an annual influenza immunization to residents and staff. Residents and staff do reserve the right to refuse if the vaccine is medically contraindicated against their religious beliefs, or outright refusal after being fully informed of the health risks associated with the vaccine. So if the employees do refuse the influenza vaccine, per state requirements, they must wear a mask when within 6 feet of a resident and during the influenza season. I think it's also important to note that staff are required to wear a mask currently in the facilities during the pandemic. So on October 16th, the U.S. Department of Health and Human Services announced a partnership with CVS and Walgreens to provide and administer COVID-19 vaccines to residents of long-term care facilities with no out-of-pocket costs. So CVS and Walgreens will schedule and coordinate on-site clinic dates directly with each facility. It's anticipated that 3 total visits over approximately 2 months will likely be needed to administer both doses of vaccine if it's indicated to the residents and staff. The pharmacies will also receive and manage the vaccines associated with the receive and manage vaccines and any associated supplies, ensure cold chain management for vaccine transport and storage, and provide on-site administration of vaccine. Additionally, they'll report any required vaccination data to public health authorities and adhere to all CMS requirements for COVID-19 testing of long-term care facility staff. And as of November 13th, all Montgomery County nursing homes and large assisted living facilities have registered for this program pending FDA approval and distribution of the vaccines. So lastly, if the public has any concerns in long-term care facilities, there's multiple options to file a complaint. If it's a resident concern, the residents may contact the Long-Term Care Ombudsman Program at 240-777-3369. If it's an infection control concern, you can report them to the Montgomery County COVID-19 hotline at 240-777-1755. You can also call the County Licensure and Regulatory Program directly at 240-777-3986, or you can file a complaint online or call the Office of Healthcare Quality at the numbers listed below. So that ends my presentation. Thank you for the opportunity to present today, and we'll be happy to take any questions.
Well, thank you, Ms. Oh, go ahead. So thank you, Mr. Lachica, and thank you, Ms. Bennett, and thank you, Dr. Gales. That was a very helpful overview of what has transpired. I want to publicly acknowledge and apologize to my colleague and friend, Councilmember Rice, who did not receive the notification that we started at 9 a.m. this morning. He and I have a lot in common, and one of it is we had parents who drilled into us that if you're not 5 minutes early, you're 5 minutes late. He's one of the most punctual people I've ever met. He even called us from the airport in Denver as he was picking up his daughter to bring her home for Thanksgiving, to just point to how dedicated he is. So, Craig, I apologize. That won't happen again, I promise. So I have a few questions, and then Councilmember Rice has questions as well. If we can take off the screen so we can get back to the joint gallery, that would be helpful. Thank you. And again, just for context, we are going to try to wrap this up by around 10:20 so that we can stay on task. And this, as I mentioned at the beginning, is the first part of two parts of the conversations we're going to have regarding nursing home facilities. We will have a second discussion before full council, and that will also include the overview of the state's role in helping our nursing home facilities. So I had a couple of questions. The first is, clearly, as my office has learned, there seems to be a varying degree of sophistication and administrative infrastructure within these nursing facilities. Ms. Bennett gave the example of the awful example, and unfortunately, I wish it did surprise me, Ms. Bennett, but it unfortunately does not, that there are some facilities that lack that administrative acumen or that infrastructure and support to be able to handle even the most basic elements of the care that they're supposed to be providing. Two just quick observations. The first is that many of the staff in these long-term care facilities are hourly workers that are working for basically minimum wage. And these are the same people who often are minorities and were disproportionately impacted within their own communities and areas by the virus. And so you had people going down left and right, people who rely on public transportation, which, by the way, is about to be severely reduced if the WMATA proposal goes through. And so there are so many underlying challenges with the staffing of these facilities, and a systemic challenge that is not going to be covered specifically by our response to the pandemic or HHS or an ombudsman. And it's part of a broader challenge that is something that we're going to have to tackle. And so my first general question is, how are we going to do that? How are we going to, address, and how are we going to look at some of those infrastructural issues as we go through sort of the next wave, which we're in the midst of right now? So that's the first general question that I have, and then I'll have some follow-up. So not sure if Mr. LaChica or Ms. Bennett, you'd like to respond to that specifically.
Well, I think to set the stage for those remarks, I think that you underscore a significant issue and a reliance that we have on elected officials and other authorities to be able to provide the policies to support from a financial perspective and, continue to advocate from the infrastructure perspective as well. I think one of the, and this is not to parse politics, I think it's one of the hard levels where we're providing health guidance, providing that support, but it is relying upon that economic relief and that economic support, recognizing those realities that you laid out in terms of the percentage, how the workforce is made up, why it's made up that way, the types of resources that folks need in order to be able to, get to places to work and execute. And I think from the staffing perspective, I know that at least locally, there's been effort to recruit, similar to what the governor proposed in terms of the staffing pieces. We'd actually implemented a number of those strategies already in terms of reaching out to different schools of nursing to provide support. And it is really a trickle down effect because we've got all of these different things that need support. And it's about trying to free up those who are most qualified to be able to pivot to do those tasks that are specific to that level of qualification. And so that I would turn to Enrico and Eileen to comment further, but that's kind of the global perspective on the infrastructure piece. If they had
So
any.
this is Eileen. I don't very often speak to the facilities and how they might structure themselves. But one of the suggestions that I might have for, as I would say, getting people to work when it comes to the facilities that are larger. Some of them have transportation buses that they are not transporting residents anywhere right now. And maybe the council itself might be able to look at some kind of an incentive for them to be using that to move their personnel to getting them to work. So that's just a suggestion because I know those buses are sitting and I see them as I drive through the county doing various things. So that might be a suggestion that you all might want to look at. Is there some kind of an incentive if we have these drastic cuts that look like they're coming for public transportation? Is there a way that we can support them having a driver on their staff that could get some kind of a credit or something? That's an example.
I appreciate that. That's a good suggestion. Mr. LaChica, did you want to respond?
That's a good point that you bring up, Councilmember. To be honest, we have not looked at the infrastructure issues. That's something that we will have to look into further, and I'll have to get back to you.
Okay, yeah, and it's a complicated response, crosses over under a number of different levels, including workforce development, but clearly one that we need to have, particularly since, as I've said many times, and we all know, the fastest growing demographic we have in our county is our aging population. So this challenge is going to increase, not get better. And we are now almost on a monthly basis on the council receiving from the planning board recommendations regarding new nursing home facilities, new long-term care facilities that are popping up around the county to meet that demand. But without the appropriate staffing and administrative support, it's going to continue to wildly vary in terms of the quality of care provided to individuals. My last question to keep us on time for now is the other huge complaint that we got, particularly in the first few months, was a feeling of lack of transparency by a number of these facilities, repeated calls that weren't being answered or with very wishy-washy information being provided, and people understandably just desperate to get some level of notification that their loved one was okay, that they were being taken care of, wanting to know data on how many staff, how many people on their floor had tested positive, what was the plan. I get the sense that we are now in a better place, much better place than we were since the beginning of the pandemic. But in light of the surge that we are in now, can you share with me your degree of confidence that those same issues that we experienced at the beginning of the pandemic have been addressed? And does the county have the administrative support and capacity to follow up on the numerous complaints that we've received in our offices and we know are being received through the Ombudsman? And then related to that, final question I promise for now, is how are those folks culturally trained? Do we have enough people who are bilingual? Do we have enough people who understand oftentimes the complex needs of our multinational and multicultural communities? And so if you could respond to that, I'd appreciate it. And then I will defer to Councilmember Rice, followed by Councilmember Glass, to ask additional questions.
So this is Eileen. I'll answer briefly. There was a lot of CMP, civil money penalties funds that were released to be able to have facilities purchase portable devices for family members and residents to be able to connect virtually. So that has improved a lot. But you're still relying on people in the building to make that connection happen. And we do continue to receive queries and consideration of, I want to call my mother and I was supposed to be able to talk at 3. Well, if the ambulance is there because there's an emergency going on, the person who was supposed to make that call happen at 3 inside is not available. So we are still continuing to get those, but certainly not at the rate that we did before. So I hope that helps. And I do think that everybody's becoming more technologically advanced. and that use of technology is encouraged and continuing, not only within our own program, but between families and residents, and between the facility staff members making those arrangements. So I would say that has greatly improved. It's just not perfect. Hope that answers one of those questions for you.
And I can speak towards the beginning of the pandemic. The regulators were not allowed into the facilities until about April or May. So a lot of the outreach to facilities was done over the phone and virtually, and we did not have eyes in the facility. I can tell you now that our regulatory efforts have been increased dramatically over the last 3 months. Every facility has had an infection control survey, and in those surveys, the inspectors also ensured that the facilities are notifying families and residents of any new cases within 24 hours each new case. And there have been facilities in the county who have been cited for failing to notify families in a timely manner. So we're confident that these regulatory inspections will keep the facilities in check and make sure that they're doing what they're supposed to do. As far as complaints, we are also going out to facilities and investigating high-level complaints. And we do have the adequate administrative support. And to answer your question about the culturally trained staff, licensure and regulatory does have inspectors from many different diverse backgrounds. We do have staff that are fluent in Spanish and many other languages, and we also have access to a language line for residents who do not speak English as a primary language.
Okay, thank you. I have some follow-up questions, but for brevity and purposes of time, and again, acknowledging this, there's going to be a part two. Councilmember Rice.
Well, thank you, Mr. Chair, and thank you for those kind words before. I'm going to be very, very quick. So when it comes to compliance, I understand that the Maryland Office of the Inspector General monitors facility compliance. Is that complaint-driven, or is that just regularly that they go and check to make sure that folks are getting tests? So if someone can just answer that question for me very quickly.
Sure, I can answer that. These are routine compliance checks done by the Office of Inspector General. The facilities are required to submit a staff roster, and the Office of Inspector General double checks those rosters on a weekly basis to make sure that everyone listed has been tested.
And so my follow-up question, sorry, go ahead. Was somebody else? Oh, no. So my follow-up question is regarding vaccination. I understand that via COMAR regs, we require staff to actually be administered the flu vaccine, but there's been no talk as of yet that I've heard of mandatory COVID vaccinations. Is that something that's in the works? Have we heard of, we're about to approach the General Assembly session. So is it something that the General Assembly is looking at, or the governor is looking at via executive order? Have we heard anything about that?
So that is still being discussed at this time.
Okay, that is a concern, and especially a concern because understanding that via what you gave in your explanation about compliance via a number of different mechanisms, there's still potential cause or potential opportunity for outbreaks if folks refuse to take the COVID vaccination and are exposed, and then bringing that into vulnerable populations. So I think it's something that we really need to just put a pin in, Mr. Chair, and certainly follow up, especially because the General Assembly is about to go back into session. If it's something that we need to do regarding legislation, and as your MACO rep, I just wanted to flag that as something that we may want to take up a little bit later. Thank you.
Excellent points. Councilmember Glass.
Thank you, Mr. Chair. A sobering conversation. So thank you for the presentation and sharing all the data. And, with approximately half of the COVID deaths in Montgomery County and in the state of Maryland coming from residents of nursing homes and assisted living facilities and other types of group homes, that's a devastating reality. And with winter season here, I fear that nursing homes again will be the epicenter of the outbreak if they're not already at the heart of it. As others have alluded to, the fact that the CDC earlier this week voted to put healthcare workers and workers in long care facilities at the top of the list for those who receive the COVID-19 vaccine. I think that's a good decision by those national healthcare decision makers, and hopefully will create a better environment here at home. With regard to the specific presentations, I really appreciate Mr. Lachika's presentation about the policies within the facilities, particularly about the communal eating and gatherings, the social gatherings, and the fact that residents will have to wear masks when they leave their personal rooms or spaces. But I think it's important to keep in mind that we cannot forget the personal and human component of these facilities. Often people who are there are isolated. They might not see anybody. Clearly, during the last few months, they have been severely restricted in the number of family members, if they're able to see them at all. And so rather than having people be fully isolated and completely lonely, I think it is important for there to be some ability for them to interact, but doing so in a safe manner. And so I appreciate the thoughtfulness and consideration to those simple human needs, but doing so in a safe way, as outlined. The other aspect of the presentation that I just want to drill down a little bit more was Ms. Bennett talking about the Ombudsman, and I'm curious, how we go from 3,200 visits last year to six this year, and I know it's, as you I think mentioned, a lot of the volunteers are older, right? But is there a need, or what is the need for those ombudsmen to get into the facilities, or might some of those check-ins that they would normally do, are they being done by the state or the county with regard to the pandemic that's currently taking place?
So I'll try and answer. First of all, again, CMS decided for us in March that we couldn't go. And then CMS at the end of September said, okay, so now we're going to revisit that, and the states have to pull together some guidance for reentry. So our state ombudsman has been working with us as a program for reentry. And we do have to look at how our program will be able to address that. We had great successes because of our volunteers. We have a history of volunteers being the extreme main presence. That has to shift a little bit, but we also have staff members, honestly, that meet the criteria right now that they are also at risk. And so we are coping and dealing with that issue internally as we move forward. So I just point that out. It takes about 6 months for an ombudsman to be able to be allowed to go out on their own. Everything else has to be joint. So that is a barrier that we have, an obstacle that we have in front of us right now to bring in new people or additional people. I don't want to say new people because we're never, it's always additional. It's always adding to. But we actually right now in the middle of December are in the midst of completing what our state ombudsman has provided to us as training for reentry. And then we have to deal with the personnel issues, which many programs within the county have for people who are teleworking and have reasons to be able to continue to telework. We actually are asking and have continued to ask of our state ombudsman and our federal oversight whether what are some of the parameters that will allow us to get in. So we are working hard on that. So.
Good. Yeah, Go ahead. I'm sorry.
Go ahead. I'm good.
Okay. I'm hearing my echo. I thought it was somebody else talking. I'm glad the state is working and trying to figure it out. Really important conversation, and glad to know that they are partners in making something happen to make sure that we can get in there and make sure that the residents are safe and that the workers are safe as well, right? Because we've all read things from across the country, and I'll say it this way: there are some unscrupulous owners of these facilities whose profits are more important than the lives of either their residents or their staff. I'm not saying that's the case here, right? But we know that to be happening, and motivations in other areas. And so as whatever we can do to ensure that the lives of the residents and the staffs are at the forefront, we need to keep doing that work. So.
And I will point out from a statistical point of view, what we are projecting some real hard evidence-based facts for us is we do not want to be the super spreaders. We, in the past, wouldn't be uncommon for an ombudsman to go into 5 or 6 facilities in a day. And we will be restricting ourselves to, at the maximum, 1 a day. So that in and of itself restricts our ability to have eyes and ears in the facilities on a regular basis.
Sure. It's not a return to full normal, but it's better than the 6 that have been done to date or so over the time period. Yeah, understood. Thank you. And then I appreciate the chair saying that this conversation will be continued. It certainly warrants it. And so just for this time period, I just have one more question, and it was regarding the PPE. And Mr. Lachika, I think this was part of your presentation. The 30 and then 60-day requirements that they need, are we checking in with the facilities to make sure that they have those? What's the process to communicate with them?
So the Office of Inspector General up at the state, the facilities are reporting their PPE stockpiles on a weekly basis. So that requirement started in November, and if facilities are unable to meet that need, then they could contact the county.
That was my next question. So they would contact Dr. Stoddard or you or whomever to try and procure those.
Correct.
Yep. Very good. Okay. Glad to know that system is in place. Thank you very much for this presentation and all that you're doing. I yield back.
Thank you, Councilmember Glass. A friend of mine who's going to be speaking in a committee session that's following this reminded me of an awful story that she brought to our office's attention of a woman who had dementia, did not speak English, and whose daughter was not able to connect with her. There was a long period of time where there was no connection at all, and she was just gravely concerned about the care that her mom was receiving and didn't know who to call. And so through her church, contacted somebody who understands the county, is very well connected, and immediately stepped in to help. She just went in herself and observed in the first person that this woman was not at all receiving the type of care that she should have been receiving and wasn't sure where to call or who to contact. And so I think it is going to be important that we invest time and energy on the establishment of the Ombudsman program to expand it, and specifically in those categories to ensure, because oftentimes, let's just say it, those facilities that are not as sophisticated, and I'm putting that nicely, often disproportionately serve our minority communities, and it's not right. And so I think that we have to step up and have the folks who are charged with being that intermediary, that lifeline that helps ensure that these facilities are meeting reasonable standards. We have to invest in that. And I also think that there's an opportunity for us through technology now in a virtual environment for us to experiment and do more than what we've done in the past. I think that we have caught up in so many different ways. And while we may not physically be able to be present within these facilities in the same way that we would like or that we need to moving forward, we can, through a virtual visit, accomplish a lot. And so that's something that, as we cross this over into our discussion into the state in part 2, something I'll be following up on and ensuring that Ms. Bennett and Mr. LaChica have the team that they need in place, because you're a mighty staff of 8, but if we have 30 facilities now that vary tremendously in size and scope, and as I said earlier, we're adding more each month because that's where the demand and growth is. Not unlike our Office of Human Rights, which we keep adding work to without the right support and administrative. We're giving you unfunded mandates here. And so it's something that we have to address and put all of us in the best position to succeed, because frankly, this is the marker of a strong society, is how we treat our elders. And so it's got to be a priority. It is, but it needs to be even more one moving forward. So those are my final comments for now. Dr. Gales.
I just want to make one quick comment to address a question that was brought up earlier for the folks watching at home. But before that, thank you for that comment. Thank you for the session. You're right. We do need extra support because the same staff that do nursing homes are also doing enforcement for all other aspects of the pandemic, and et cetera. So we do need the support. But I wanted to clarify a point that Eileen asked earlier and mentioned that a lot of the long-term care facilities have been asking about, will they be included in the vaccine case since they hear mostly nursing homes? I want to read to you the exact wording from the ACIP recommendation that was approved yesterday that says, when a COVID vaccine is authorized by FDA, COVID-19 vaccine is authorized by FDA and recommended by ACIP, healthcare personnel and residents of long-term care facilities should be offered vaccination in the initial phase of the COVID-19 vaccination program, phase 1A. Long-term care facility residents are defined as adults who reside in facilities that provide a variety of services, including medical and personal care, to persons who are unable to live independently. So I want to clarify that it's not just nursing homes, it's the full spectrum of long-term care facilities. Now, I will put out a caveat, though. There is limited supply, and this won't happen overnight, and it will take some time to get distributed. But just wanted to ensure that they understood that long-term care facilities, not just nursing homes, that will be included in that first wave. And to the point about mandate, part of the reason why the mandate has been still being discussed and not firmed up one way or the other is, let's keep in mind, all of the vaccines right now are still at experimental stage. None of them have actually been approved. So once those guidelines are released, I think those conversations related to mandates will move forward, whether they are put into place or not. Thank you.
Great. Well, thank you all. That was, again, a sobering and important discussion. There will be a second follow-up after we come back from our recess, and we'll make sure we carve out sufficient time because all 8 of our colleagues are going to have questions too. So thank you again for all your hard work, and we will follow up in the next round. All right. Next, we are going to get 2 very important updates regarding 2 stellar initiatives that have been put forward to address the growing needs that we have had here in our community. And we're going to start with an update from our African American Health Program. I want to give a lot of credit to Council Members Rice and Jawando, who have worked with the incredible leaders of AAHP and the Executive Committee, as well as the Department of Health and Human Services, on creating a targeted approach to address the disproportionate impact on our African American community, who to this day continue to have the highest percentage of deaths related to the pandemic. And many of the public health issues supersede the pandemic and are now frankly on steroids, but there have been some really impressive returns and an impressive strategic approach to address this, as we will hear from. After we hear from our colleagues and friends and within the African American Health Program, we will then receive an update from our colleagues and friends from the Latino Health Initiative. We are joined today also by 2 of my favorite colleagues, Councilmember Navarro, who, along with our team, helped stand up the Latino Health Initiative, which served as the template and initiated the more targeted approach to our minority communities. And we are also joined by Councilmember Jawando as well, who, as I said, has worked closely with Councilmember Rice and the AAHP team. And once again, I want to acknowledge the incredible work of Linda McMillan, who doesn't just put together these very impressive and comprehensive packets, but every day serves as a link and as a bridge to the council and our administrative staff and our offices in helping to stand up these programs. And she's just an absolutely invaluable public servant, and I want to once again acknowledge her. Joining us on this first panel is Ms. Beatrice Miller, the co-chair of the African American Health Program Executive Committee, Ms. Jacqueline Williams, who is co-chair, Pat Grant, the immediate past chair, Arlie Wallace, the program manager, and of course, Dr. Raymond Crowell and representatives from his team will be on this call as well. First, we will hear from AHP, and so I turn this over to you. But actually, before I do, Ms. McMillan, was there anything that you wanted to say or some context that you wanted to provide before turning it over to the AAHP team?
I believe that the presenters today from the executive committee will give you all the information that you need to know about the update. But I did actually just want to say that they are here as representatives, but it's the full executive committee that really is the catalyst for this. And so I did want to recognize some of the other folks who are not on the Zoom today, but are really critical to this effort. And that includes Art Williams, Karen Williams, Deborah Wiley, LaDonna Howell, James Stowe, Crystal DeVance Wilson, and Jessica White. And then there is a long list, too long to read, of really important partners in this effort that are out in the community. And if you visit the aahpcovid.com website, you will see a lot of those partners. You'll see really wonderful videos from Fit Fathers and some of the other folks. So I just, before turning it over to the presenters today, I just did want to say this is really an incredible effort of the full executive committee and a long list of community partners. And with that, I would turn it over.
Thank you. And actually, before we start the presentations, I do want to give my colleague and friend, Councilmember Rice, to say a few words, and Councilmember Navarro to say a few words as well. Councilmember Rice.
Well, I first want to start off by thanking you and Mr. Vice President and Chair and Councilmember Navarro, because it was your discussions at the beginning in terms of saying that we needed to focus on our communities of color here in the county and really understanding the need that was there. And we needed to have some nuanced approaches to how we would best serve our communities. And I just want to close by saying one thing. I had a comment that came in via Facebook message from a person that I don't even know. And they said to me, Craig, you don't know me, but just wanted to say good looking out. By putting AAHP in the community, you really helped to make sure that you're going to save some lives. We recognize this and appreciate the great work. Keep it up and make sure that you continue on, brother. This is what it's about. People in the community. And so thank you to AHP. Thank you to Dr. Kroll. People who we don't know see the work that's going on and see how important this is and know that sometimes we have to bring things to the community. Some things we have to make it even easier, understanding that there's so many challenges that stand in the way beyond just the simple fact of distrust that historically has always been there with health services in our communities of color. We have to recognize that if we want to try and get beyond some of the challenges we face. I am very concerned about what will happen with vaccination distribution as I talk to these same folks. And I think that this is the catalyst. If we didn't do this, it would have been even harder for us to get vaccinations out to our communities of color. But by having the testing and then trusting going in and getting the testing, it actually bridges the gap for them to actually trust then going and getting a vaccination. And so I just really want to, again, say thank you to everybody doing the work. You guys have been out there in the community. Thank you so much for what you're doing, because you truly are, as that young man said, saving people's lives. So thank you.
Thank you very much, Councilmember Rice. Councilmember Navarro.
Thank you, Mr. Chairman, and thank you, Councilman Rice, for those remarks as well. I am always struck by how things happen and how sometimes things are just aligned. And for so many years, we have been so proud of the work of our minority health initiatives. And there were some years where the resources were scarce and we did everything we could to make sure that we would not take away resources, make sure that we would reinstate those resources, because it was all about prevention and it was all about addressing the health disparities that were so persistent in our county when it came to our communities of color. And so it's incredible now to realize that all of that work that these extraordinary leaders that comprise the committees, the entire initiatives, those who were there advocating and sometimes, shaming folks for trying to dilute the situation. It is extraordinary to realize, and I literally get goosebumps, to realize how fortunate we are that these structures were put in place when they were put in place, because this has been the ultimate test. And so it was just a no-brainer when we kept looking at the disaggregated data by zip code and understood who we were talking about. It was a no-brainer that we needed to come up with a targeted initiative, something that would speak to the nuances of our communities and that would target specifically those areas and those ongoing needs. But in order to do that, we also needed buy-in from the leadership of the department that had to, run all of this. And so really want to thank Dr. Kroll for stepping in there in this role and really providing that leadership. I want to thank, the leaders of both initiatives for stepping in. And as it was said, Ms. McMillan, who, worked around the clock during weekends to turn this around, and everybody who is really on this call and some who are not, who did the same thing. It was in record time that these initiatives were stood up. And what an extraordinary thing it is to visit some of the events, as well as some of the places, the clinics, et cetera, and see folks from the community taking advantage of these very important resources. Because if they're able to do that and protect themselves and their families, then everybody in the county and the region can also be protected. So I just want to really express my deep gratitude. Yes, it was, something that came up out of the concern of where the data was going, both for our Latino community and our African American community. But the reality is that everybody put in their part, did their part to make this a reality. And now really is the model that has positioned us so well for what is coming. So thank you very much. I just really want to express how extraordinary this has been and what a template this now has become. Thank you, Mr. Chairman.
Beautifully said by both of you. And humility is a quotient I really value in leadership. Normally, Dr. Crowell would step in, but he has said specifically he'd like for AAHP to give their presentation first. So Dr. Crowell, I just want to say just your leadership here and that of your team and your support has been extraordinary, and we're going to hear from you in a little bit. So with that, turning it over to AAHP now.
Well, thank you, everyone. And special thanks to Craig Rice, Will DeWando, our councilman Gabe and Nancy and Hucker and of course Linda McMillan. Thank you for this opportunity. Let me get started because I want to keep it moving here. Do Black Lives Matter in Montgomery County? I think we've been saying this for several years now with our geographic hotspot study as well. The National Medical Association, which represents 50,000 African American physicians, has blamed the high death rate of African Americans on a amplification of years of discrimination unequal treatment and injustices in healthcare, criminal justice, and employment. The coronavirus disease 2019, of course, is a respiratory illness that is highly contagious and can spread from person to person. COVID-19 was first reported in the U.S. on January 21, 2020, and first reported in Montgomery County, Maryland on March 5, 2020. Those at higher risk for contracting COVID-19 include persons with serious underlying medical conditions, such as heart disease, diabetes, and lung disease. African Americans, that is blacks, are disproportionately affected by these underlying medical conditions, hence are at higher risk for contracting coronavirus. Therefore, it is important that all approaches addressing the current pandemic must include specific strategies to help this vulnerable population decrease their risk for increased death rates. AHP has continued to track the spread of new cases, hospitalizations, and deaths in both Maryland and Montgomery counties. The data also show that African Americans, blacks, are disproportionately represented among victims of the coronavirus infection. You know, in Maryland, there are 201,135 confirmed cases of the coronavirus. And so we are, as a state, considered a hotspot in terms of the virus. In Maryland, blacks still comprise one of the highest number of cases of coronavirus, as well as almost the highest number of cases in terms of its highest among all the minorities, but very close to the number of deaths from corona compared to the white population as well. We are a smaller population in Maryland, about 18%, yet almost 30% of the death rate in Maryland. When we look at deaths by race and ethnicity, what we notice is that the total death count, considering our smaller population of about 18%, we have a death rate among our population of 96.1% compared to the higher population of our whites in Montgomery County. They comprise about, was it 47%, I believe?
Yes, this is Beatrice. It's 43% of the population that whites are. And so as you see, the total death rate for blacks in Montgomery County is 96.1. Our death rate is the same as whites, and our population is 18%, and whites are at 43%. So we thought that that was pretty significant, that our rate is mirroring the population that has more than we do, more people.
Thank you, Beatrice. We'll move on to the next one. And in terms of our, of course, our infamous geographic hotspot study, what we've done is look at what the particular zip codes from our geographic hotspot study, and we noticed that in terms of the county deaths by zip code, our hotspot, we got 20% of these, 20% of the population in these particular zip codes are recorded as deaths. And that's where the blacks really reside. And that's one of the things that we're trying to address, is to focus on particularly our geographic hotspots. And it mirrors what we already said a few years ago. In terms of our overview, the increase in the number of Black Americans, of course, this includes African Americans, people of African descent, and Caribbean. That is our target population. We provide educational information and provide HB COVID kits to African Americans, Blacks in a hotspot at our testing sites. And this is something that we're very proud of because this allows us to encourage our Black population to follow the CDC guidelines. And also, it allows us to provide long-term services for our Blacks who are positive and negative and who have these underlying health conditions and increase the risk of death from COVID. Follow-up monitoring, and we provide the follow-up monitoring as well with our nurses and as well as our budding physician, Black physician network. And we're very excited that we'll have a way to go in the future with the vaccines to reduce the death of. We have the mechanism in place to reduce the death rate for our Black population with our support services. The goal is to decrease the death rate, again, of the target population. And what we show here is that when we got started, oops, I lost my little, there. When we got started in end of October, the state had already was already showing a dramatic increase in the number of deaths from COVID, and we got started about that time, and so we were very excited to help at the need at this particular point in our state's COVID history. So our objective, of course, is to dramatically increase the number of Blacks receiving the COVID test. But we also want to increase the number of Blacks that receive vaccinations as well going forward. And the idea is to identify first those who are positive and allow for mitigation and remediation to reduce the spread of the virus. But we also, at the same time, looking forward to helping to increase the number who are vaccinated in order to help stem the spread as well. Now, our catalyst has been identifying African Americans, Blacks, to determine who is positive and who is not, so that they know how they can assist in stemming the spread of the virus themselves, that we can help them in determining whether or not they are infected, and of course isolate themselves so that they can participate in reducing and mitigating the spread. So we've been very happy that we've been able to help identify people, and hopefully that increased the ability of the county to reduce the spread in general as well. And again, I think I mentioned our research project on the geographic hotspots, which we, of course, are very proud of. And so to date, as a result of that initial survey, and then our ability now to locate our our Black population in those hotspot areas and also other areas of the county. On October 29, 2020, we started at Damascus Gardens in Damascus, Maryland. AHP COVID response had 13 test sites in our designated hotspots. We partnered with Black churches in the community to host 18 test sites. We also partnered with HOC to host 5 test sites, as well as a housing community in Damascus to host 2 test sites. So far, we have tested 2,107 clients from a very, from actually beginning from nothing. We had no structure, nothing in place until you graciously funded this project. And so we've reached this point so far. We've gotten all these partners to help us, and everyone has stepped up to the plate, and we couldn't be more delighted. And Beatrice, I have to tell you, I can't see this chart.
Oh, this is our, and I just put this in here. This is our distribution of our population with greater than 20% of Blacks or African Americans of the total residents. So this is our geographic hotspots. This is where Blacks live. And so this is where we have been targeting.
Thank you, Beatrice.
You're welcome.
I can't see this one either.
This one is from the Montgomery County website. And actually, I highlighted our geographic hotspots and where there has been, this was as of 12/1, I think it is. And this is where there was a noticeable change in the average daily cases of residents. And they are in our geographic hotspots. So we just wanted to make sure that, you know, the county council understands that the data has been consistent, that the largest number of cases are recorded in our zip codes, our hotspot zip codes where Blacks live, which are 20906, 20904, and 20903.
Thank you, Beatrice.
You're welcome.
Okay. So, you know, and we continue to, you know, I think we're saying our data that we initially found and included our study back in 2019 still reflects the vulnerable population of Black folks in Montgomery County. And sadly, and of course, during these initial testing, what we found is that 55% of concern of our we have sorry, get rid of this phone call. We have AHP COVID response has 55 confirmed test sites through December 30th, 2020. So we still have more testing to do, and we're excited to complete this particular phase of our program. My phone will start ringing.
Okay, so I'll start with this. This is our, this is one of the things that we have, we are very proud of, and it's our COVID kits that we've designed, and we really think that we wanted to start with these COVID kits because we really want people to change their behavior, right? Socially distance, take your temperature, wear a mask, gloves when you're out in the grocery store, sanitize and wash your hands, and then clean the surfaces. And so we distribute all COVID-19 kits to all clients who complete a COVID test. And this is a picture of our COVID kit. And as you see in there, it has hand sanitizer, masks, gloves. We have cleaning supplies and a thermometer. So we wanted to, with our marketing and communication, we really wanted to establish an effective communication strategy, which we have done. We really have been able to promote our COVID. We have a website, and so we really think that we have been really successful in this. We have targeted events. We just were at one of the HOC senior buildings Monday, I believe, and we are planning a Black veterans event in I think it's 2 weeks. So we really are focusing on our targeted population and our most vulnerable populations as well. So again, our strategy has been very successful. We have our dedicated website, we have targeted marketing, and then we have highly visible media. This is one of our buses. We're hoping that you've seen them riding around Montgomery County. And then these are our promotional efforts. I've done a video. We have a promotional from James Brown, God Lambert. I don't know if anyone's seen it or if I can play them.
And Kojo Nambi.
Yeah. We did Angie and Ange. Let me see if I can. I don't know if I can play it. I don't think I can. Oh, wait. Oh, no, something's happening. One second. I think I can get it to play. I've got to switch.
Hi, this is James Brown, and as you know, coronavirus infection rates are rising, and Black Americans are being hit especially hard. As a Montgomery County, Maryland resident, I'm happy to share that the African American Health Program Executive Committee and Fit Fathers are hosting free holiday COVID-19 testings in Montgomery County. Visit aahpcovid.com to find dates and locations. Make your health a priority, so don't stress. Take the test. Again, that's aahpcovid.com.
Were you guys able to see it? Oh.
Yes.
Good. I was just at the technology. I'm trying. Okay, let me see if I can find the share my PowerPoint again.
Okay. Beatrice, better you than me, because you know I can't do that.
I was going to see if it works. Okay, so we have it. So please check out our website because it does have a lot of information. And so we're really proud of it. So we have community outreach. So we had this as a strategy, and we actually put a few dollars on it because we notice in our community there's a lag in our the Blacks getting the flu vaccine, and so we realize that there needs to be an aggressive approach to make sure that we're provided robust and culturally competent education regarding the COVID-19 vaccines, which are on the horizon. In addition to community outreach, we'll need to partner with healthcare providers, community organizations, and churches to educate and encourage our targeted population to get immunized. And so we found some data and charts to show that the vaccination rates between Blacks and whites over the last 10 years with the flu is lagging. And so we feel like we have a compelling argument. So as you see here, from 2010 to 2019, Blacks were one of the lowest recipients of the flu vaccination, adults 18 and older. And if you look here, this is from all people 6 months and older, and we lag here as well. 45.7%. And then we have a difference, from 2018 to 19, 1%, give or take, plus.
I think Beatrice may have.
Beatrice?
or minus 1.8. So we feel like, hello?
You froze for a little bit, but you're back on.
Oh, I'm not, okay, good. I'm sorry. Where did I lose you? Did you
You're
get
fine.
Okay. All right. So this is our flu vaccine. So we just feel like for the COVID vaccine, we're really going to have to work with our population to get that done. We have nurse navigators who have been calling all of our positive and negative clients, as well as giving education. And I had my COVID test, and it was wonderful. They remind us about socially distance, wear your mask, wash your hands. They give that education. And so our nurses have made 3,788 calls between the 1st of November and the 1st of December. So they have called a lot of people. So for mental health, as we all know, mental health, there are behavioral disparities. They've existed before, and so they have continued. And just, I can think for myself, just being socially distant from my relatives and my family who aren't even here in Maryland, as well as my friends who are here in Maryland. It's been very challenging, just trying to stay connected, and it's just hard. So we have, again, put a lot of effort around mental health. So as you see here, we have a dedicated resource team. They're available by email or telephone. The team, they provide support, education, and resources for the Black community to reduce the impact of COVID-19. We also have a family mindfulness support circle, which is every Wednesday at 6 p.m. And so we think that we have resources for our community to really help tackle the health impact of COVID-19, especially around mental health. We also have a domestic violence helpline, which is now staffed daily, 24 hours a day, 7 days a week. And, as the data shows, there are domestic violence has gone up, and then the fact that women have to stay within the home because of COVID, it's just not very untenable. And so we have some help for them. As Jackie spoke earlier, our Black Physician Partnership, we're working on that. We really think that this is innovative. We really think that having physicians that look like us, taking care of us, is the way to go. We have identified, and we are continuing to increase the network of African American and Black primary care physicians, whom our nurse navigators and social workers can refer Blacks to both positive and negative. Studies have shown that Blacks fare better when they are seen by Black physicians. Dr. Marcella Alsan in 2019 completed a study, which I have here, that you can look at, and then Science News.org had a study as well that talk about Black newborns who are cared for Black doctors are less likely to die than those with white doctors. And of course, we have our SMILE program, so that was very interesting to us because that's something we really do need to tackle. Food security is our next measure, and we are looking to increase the rate of food security for African Americans and Blacks. So as you know, with unemployment, there are just a lot of people in the food lines. And so we're working with our partners to make sure that our COVID positive clients receive meals during their quarantine period. And that's to reduce the transmission of COVID by really reducing the need for them to go out to get groceries. And then we have strategic food distribution at COVID test sites to provide meals for clients to improve their food security. So we've distributed 111 meals to seniors, and we provided meals during quarantine for 13 of our positive families. And they ranged from family members from 2 in the family to up to 7. So we've given them enough food for 14 days. And our last strategy is our data collection and analysis. And we have our data analysis who's looking at measuring some of the disparities. And so this is just a snapshot of some of the things that he's found. But we've been successful in testing our Blacks. We've done 52% of the tests that we've done. Well, actually 56% have been our targeted population, which we're very pleased about. This is some of our sample of our data collection forms that our vendors do for us, so that our data analysts can collect our data. Jackie, you want to go over the budget? Okay, well, because I don't know.
Oh, wait a minute. I'm sorry.
Okay.
We have this little one in school. Had to turn around a minute. In terms of the budget, we use FEMA funding for the testing. We have a vendor who was working with us. We have a vendor who is working with us to conduct all the testing, picking up the materials and getting them to the lab and so forth. And most of our tests, of course, were drive-through. We had a few at the housing projects, the HOCs, for instance, that were walk-ups. And so we want to continue with our funding for testing, and we're stepping up the education component, particularly with the vaccine on the horizon. And our marketing has been quite robust and targeted. And I think we've gotten, I think we can see that we've received actually more interest in getting tested due to our marketing efforts. So we want to continue that. We're also continuing our outreach efforts. In fact, we're also trying to increase our outreach efforts, including targeting our veterans as well, of Black veterans. The nurse navigation, where our nurses actually are not only calling those who are positive and negative, but also doing wellness checks for those who are positive to make sure they're okay. We certainly don't want anyone who is positive to end up feeling fatigued one day and 24 hours later they're dead. So certainly we want our nurses to continue with their navigation efforts. And I think Beatrice mentioned our mental health. We're actually going to be stepping that up more as this virus continues to ravage not only our community but our country. And it's, and of course COVID fatigue is setting in. And so there's a need to keep stepping it up so that, and with the mental health dollars, that will help alleviate some of those issues. Our Black Physician Partnership and our co-pay assistance, as I said, it was in our infancy, but we are stepping that one up. People are very excited about this. We are, and the physicians are. And so with the vaccine coming on the horizon, we are certainly going to be able to utilize the Black Physician Partnership as well. Our food insecurity, as I think Beatrice mentioned, that food insecurity is rampant throughout not only the country, but particularly here in Montgomery County in those hotspot areas, to be sure. So we will continue our efforts with the food insecurity as well. Our data collection analysis, doing a great job. We have a highly skilled statistician. And so we're very happy with what this person actually works with each of the other components of our program to make sure that all the tracking is being done appropriately, and so that we can report every 2 weeks to our executive. And so that's a person who is highly needed for that particular activity. And so we are requesting a $3 million budget again to help us continue these efforts. In terms of our functional chart, our organizational chart, as far as we can see at the moment, I think we've kind of covered all the bases that we need. We may increase some areas, as I said, mental health will be one of those. Our Black Physician Partnership will be another. Educational information, for sure, will be another piece. And of course, in terms of testing, that will continue, but we're also looking forward to vaccination. Because we all want this COVID to end. First, we all want that to happen. And so just want to let you see how we were organized, and I hope that this is helpful to you, that you have a better understanding of what we are trying to do. And I have to say again, once again, to all our council members who, everyone helped us, everyone pitched in, and we could be more delighted and excited. Thank you.
Well, Jackie, thank you for that presentation. It was incredibly impressive. What we're going to do is now get the presentation from our Latino Health Initiative. Since there's a lot of commonality in the questions that we have, we're going to come back to the joint panels to then follow up with questions on this presentation and the one we're about to hear. And for logistical purposes, we still have another joint Education and Culture and HHS session to discuss special appropriations that must be introduced next week for them to be enacted. And that one will be on cable TV. And so there will need to be a 5-minute break in between the completion of this section before we go live with the joint committee session to allow county cable and the technology to catch up. So we're going to aim to finish this session between 11:45 and 12 and then around 12 o'clock start the next session, just for purposes of my colleagues. So with that, all the same superlatives apply to the incredible members of our Latino Health Initiative who have stood up a really remarkable program that is exemplary, as is the African American Health Program, that I think the hope will last beyond just this pandemic. And I'll note quickly with regards to funding, we have been assured by our colleagues in the executive branch and by the Assistant Chief Administrative Officer that the County Council will be receiving a proposal that we will be able to act upon to ensure that through general funds, not just the FEMA funding or the CARES funding that runs out, so that these programs will continue. So rest both initiatives, be assured that these programs will continue. So with that, I now turn it over to, I believe, Dr. Michelle LaRue from the Latino Health Initiative. Dr. LaRue.
Thank you, Council Member. I want to start by thanking the HHS committee council members, Council Member Albornoz, Rice, and Glass, as well as Council Members Navarro and Jawando, and a special thank you to Linda McMillan for all of your support and guidance throughout this process. I also want to congratulate Councilmember Albornoz for becoming the Vice President of the Council. We're going to each give a quick update and overview of the different branches of our program. So I'm going to pass it off to Doctora Izquierdo to start us off.
Mute myself and share my screen. So let me know if you can see the screen, please.
We can see it.
Okay. So we want to share with you a little bit of what's been going up to date. And the first thing we always share when we talk about this program is how it all got started. And it got started with this graph. Nancy and Gabrielle brought us together to a meeting sometime in June. I don't remember, it seems like a million years ago, and showed us some data that was disturbing. And the same as the deaths in our sister organization, the rate of disease in our population was very disturbing. So after that, we started working with the county executive and Dr. Cowell. And we actually, I think this is one of the fastest programs I've ever been part of. In a partnership with government, within a month, we essentially had designed and had funding and the support both of the council and the executive to get this going. So whenever I talk about this program, I just always have this slide because for me, this is one of the most impressive partnerships that I have been part of. So one of the things that was important to us, and for anyone that is familiar with the work of the LHI and the steering committee, we have always considered the issues of health disparities to be in need of a system-based approach. You know, it's not about diabetes, it's not about COVID, it's about the system that supports our communities. And thus we designed this project to reflect that belief. It was not only about testing and contact testing, but it also had to have some case management to look at the social determinants of health. It had to have communication. It had to have a very important piece, which is the health promoters out in the community providing education. The phone lines to provide the information needed to be in Spanish, in a language that could actually be accessed by our community. And then we had to make sure that we would collect the data, as our sister program was mentioning, to make sure that you guys get your bang for your buck, so to speak, and so does our community. So in terms of doing this, we have brought together a lot of partners that have long histories of working for the community and understanding the community and have the cultural and linguistic competence to take a project of this magnitude in the amount of time that it was asked of us. So we always, when we present our partners, the county is smack in the middle because this is truly a partnership, but so are a lot of the other organizations that have been part of this effort. So I'm going to talk to you about three elements, which is the testing, the hospital at home, and the data. And then I will let some of my colleagues also talk about this. So around testing, we have tested 25,000 people, but you can see the timeline. The last week we've tested a little bit under 10,000 people. It's been, people are more interested on getting tested. Thanksgiving was a killer. I mean, we had almost 1,000 tests in a day in a couple of partnerships and a lot more than usual. So we'll see what happens this coming week. We expect it to be a little bit lower just because the Thanksgiving craze was over, but you can see a steady increase in the testing trends. And the next slide I'm going to show you needs to come with a little bit of, this is partial data, okay? But when I saw the graphics, I thought it was worth presenting it to you. So overall, if you look at from August that we started testing to today, we have around a 5% positivity rate, which is consistent with what the county has been showing. But if you look at the 2 last months, we have had testing days that have been up to 14% of positive cases in the community we're testing. So we are seeing a big increase of positive tests as we take care of people. And that means not only that, we have our nurses and our clinical staff reaching out and making sure that we connect these people to whether they have their primary care or if they don't, to one of our clinics to ensure that they actually have care. But it also means that there are a lot of hotspots that we need to track and that we need to make sure that people are staying safe and doing what they need to be doing. And you can see, come rain or shine, it's really true. We do test even when it rains, but important sort of looking at the general trends. Issues that we're having right now with the testing are really about the volume. We, are taking longer. For instance, yesterday, we started receiving some of the tests we had done on the 24th. So the lab is also overwhelmed. It's not only the clinics that are doing a huge amount of volume, it's also the lab is taking, and with the Thanksgiving holiday in between, it was a little bit crazy this last week. But this is something we're working to look at how we can tackle the volume. The giving out the results, again, the positives always get a follow-up and make sure they have an appointment. And then we some people call the negatives and give the education, some people give automated. So we're working towards a more standard way of dealing with negatives. And then the other important piece, I think, and my colleagues will tell you, is the presence of health promoters within the testing allows for a lot of education to be happening during the testing. And this picture particularly is a tester and a health promoter working together during a testing event. I think those are the most important pieces. The hospital at home, which initially we called clinical follow-up, but it got confusing because the clinical follow-up is what we do after the testing. What this program is an attempt to provide a little bit more comprehensive support for people to allow them to stay at home when they don't need to go to the hospital, right? They're short of breath, their oxygen is a little bit low, but we actually are able to monitor them through a remote monitoring tool. We have daily nursing rounds, so they call them and they check on them. We check their vital signs. We actually just are getting some remote stethoscopes, so the patient can have them at home and we can hear their lungs from a remote location. So that's going to be happening in the next week. And then the provider, whether the doctor or the nurse practitioner, also does daily visits. We started late. Part of it was because it was a prolonged recruitment because we needed the linguistic competence to be part of the people being recruited. And it was surprising to us, but the remote monitoring people are so overwhelmed with sales across the country that it took them also a while to be able to complete that contract and get it going. So we are taking patients. We have currently one patient admitted with bilateral COVID pneumonia. And we are ready to ramp this up quite a bit. What happens is, depending how you do, we end up discharging you to your primary care, putting you in contact with one of the clinics in the community, or sending you to the hospital if that is, if we cannot keep you safely at home. So this is going to be, as I say, ramped up pretty fast now that we have all the pieces of the puzzle in place. Next, I'm going to show you the dashboard that has been created for this project. This is, you can actually connect from the website. There's this partner portal, and you actually go to the dashboard, and the dashboard allows you to hand enter both patients and events. So if the promotoras are out giving education, they can do it without the specific information of the patient. Anything communication-wise is documented here. And then we committed to doing 3 reports, one with missing data so that we could track how well we're doing with the data. One is a utilization that is ready for us, and so it starts showing this is the lab result, and we have a number of utilization reports that are available. And the one that we committed for this project until December, which we're working and will be available in the next 2 weeks, is the geolocation, where we will be able to show you, if you tell me positive results by geographic area, we'll be able to plot it and you'll be able to see those. So that is also going at the rate it was needed to go. We have the IT support to help people with the database, so we make sure that there are no issues in terms of IT technology. And I'm going to pass the baton to, I believe, Diego, to talk about the case management.
Thank you very much, Ana Maria. If we can stop the sharing so we can see.
Yes.
So thank you, and I want to ditto all the thank yous that Michelle gave out, and I want to add Raymond and Sonia. Without their leadership, we could not have done the tremendous efforts that we have undertaken. So very quickly, case management has served 4,000 clients to date. The 3 top issues are short and long-term food security. Second, health. And health, I'm talking about COVID and other non-COVID related issues. For example, patients, clients that have cancer, diabetes, and other conditions and they need support in order to maintain their medications or have access to doctor visits, etc. And the third one is emergency assistance, and the top two categories is help with utilities and rent. At the beginning of the program, we saw more or less 30 to 40% of our clients to be high needs clients, or what we call high risk clients. And right now, it's almost 100% of the clients are dealing with extreme situations. Unfortunately, we have many clients who have been affected by COVID, and the 2 breadwinners, we have had COVID-related deaths in the families, and that has had tremendous impact on the livelihood of the families. Loss of jobs is huge in the community. So people are struggling in ways that we have not seen before. And again, before it used to be 30, 40%, and now it's almost 100% of the clients. One of the things that we really want to emphasize is that at least the case management project within Bienestar could not function without the county's other supports. Emergency rental assistance, the support to MANA and others. We cannot work without that because, again, the families are in desperate needs. We've never seen this before. The one recommendation that we would like to make is that, unfortunately, some of the county's support programs are being overwhelmed. I'm referring particularly to 311. We refer lots of clients to emergency rental assistance through 311. The last time we spoke, they are dealing with cases from September. And it takes usually an hour to get someone to respond to the call. So that it poses a huge burden on the families that need support yesterday or a month ago. One of the ideas that we have, when Bienestar case management gives support and emergency assistance, usually it takes us a week to turn things around. except for ERP, that is now sending checks automatically. Others really take a long time. So we are wondering if there's a way to continue to have the main support via 311, but dedicate some of that or transfer some of those fundings to pipelines that are not as saturated as 311 are. Could be Bienestar, but also could be others, because our turnaround time is a lot faster. Obviously, if we have the caseload that 311 has, we will also be in trouble. So that's it for me, and I'll pass it along to, I'm not sure who, but one of my team members. Thank you very much.
Thank you, Diego. Next will be Grace talking about the hubs.
Hi, everybody. Can you hear me? I am going to be brief because I know all of you get the reports. But before I do that, I just want to acknowledge the incredible partnerships that we have developed. Even before this proposal, we created a really good partnership with Ana Maria's Care for Your Health and with Identity. So this whole Salud and Bienestar was truly an answer to many people's prayers. So many of you know about the hub concept. Our colleagues from the African American Health Program talked about the whole instability and of food insecurity in the county. Unfortunately, the numbers keep going up. So the need is there. We're entering winter, and we're seeing people actually, like Diego said, in record numbers. They're losing their jobs more than ever. We also do a lot of door-to-door deliveries for people who have no transportation, folks who are diagnosed with COVID, folks who are quarantining because of COVID, and we have seen the devastation of this disease with many deaths in families that we serve. And as many of you know, the concept of the hub was born just to help about 20-some families at the Trailer Home Park in Meadowbrook, and also through the generosity of Black. And I'm just going to have Lynn wave from BlackRock through their generosity of BlackRock opening their doors. So they're currently now, and by next week, the 8th hub is going to be opening its doors. The 8th hub is going to be actually at Interfaith Works. Super excited, helping them with recruitment and so on. So pretty much the concept is to help those in that community 20906 and 20902 throughout India. We are serving at the Germantown one. Sorry, there was some technical difficulties, I think. Can you still hear me?
Yes, we sometimes we turn off video because when you have video and audio problems at the same time. But we can see and hear you right now.
That's true. Okay, good. We are actually, just to give you an idea, so far for this week alone, we have already served over 500 families. 600 families, and that's without today and tomorrow. So today we're probably going to be reaching over 300, and tomorrow a couple other hundred. So we are already reaching that over 1,000 family threshold. But you guys get all the reports. I just wanted the community to get a little idea what the hub is, and you can go to our website, the Latino Health Initiative as well, and there's information about where we are, and people can call. I just wanted to give you just a small story of how the hub connects all these programs, right? We work very closely with Care for Your Health. We do testing with them. We order flu shots. Thank you to Holy Cross. We order flu shots to be able to serve those communities that we actually take the food to and take testing to as well. We had a family that their kid needed a very serious eye surgery, and it needed to be done quickly. Otherwise, this 16-year-old was going to lose sight on both eyes. And through one of our partners, Visionary Eye Doctors, we were able to connect them with, and it was so specific that it just happened that this practice, that's 1 out of 2 that can do this in the whole like DMV area, because they have the special whatever thing they need. It's called keratoconus. And because they were, they were trying to navigate through their own ways, and they could not find it. It was $20,000 for each eye. We were able to connect them, and that young man is now recuperating, and he's going to be fine. He's going to be able to retain his eyesight. But situations like those, which otherwise would have been very difficult to navigate during a pandemic, we're able to connect, and we're able to serve a community that otherwise is not connected with other services. We're doing holiday giving, and only 100 families from the trailer home were on the list of holiday giving, which means 100+ families were not connected in any way, shape, or form. When we did Thanksgiving, every single family got what they needed as food sustainability. We literally went to every trailer home and make sure. And we're doing the same thing for Christmas. But with that, we're also connecting them to services to identity, services to care for your health, and others. And I just want to say thank you to a couple of people, because Mark Hutch is one of the folks, who helps us with a lot of this. Diana Sato also. And these are some of the folks, right, you don't hear about so much. Linda McMillan is amazing. And thanks also to Raymond Crowell, because now we have a HHS navigator. And you heard about how overused 311 is. And we have some families who are in true need of getting the help yesterday. So we have now this navigator, and we're hoping that that's going to be replicated with the other hubs. And she's able then to be able to get these families under her wing and walk them through what they need, whether it's rental assistance, access to healthcare, and so on. So truly, this is a great partnership with private and public. And we have incredible partners like KindWorks, who's also providing a lot of the volunteers throughout the county. So thank you to you, Gabe, and Nancy specifically for bringing us to the table originally back in June, and to everybody and to all the council people and on the side of the executive as well, and to Rich Madalena for supporting and believing in these efforts.
Thank you, Grace. I want to just jump back really quick to the testing and give Maria and Agnes a quick minute each to talk about the testing activities, and then we'll proceed to talking about the promotoras and some of the other outreach.
And just a quick time check, if we can try to finish the presentation in the next 8 to 10 minutes to give enough time for questions, that would be amazing. Thank you.
Okay, I'll try to be really quick. I just wanted to reiterate that one of the other things that this project is doing is really bringing people into primary health care, both in person and telehealth, and particularly around pregnant women and children being immunized on a timely basis. The amount of people that are coming in for dental care that just are have horrible dental problems, it's been really a great project to bring those people into care. I also just want to say today that, besides the regular job that the Latino Health Initiative staff has, I just want to commend them for the extraordinary job that they do with the logistics, because we could never, none of us could do the work that we do without them acquiring the site, setting up the date for during the testing time, the day of, and just the essential details that make the testing day really successful. And for serving as a liaison between us, right? Exactly what's happening today with the county executive, the council, with other HHS agencies and other agencies in the county. Those logistics are primo and really important in the coordinating, right, of all the program components that you have just heard to be impactful for the community. And I'll finish by saying that this is really, truly the best example of transformational care that we can bring our assets of both government and the private sector, and coming together, we transform communities tremendously. So thank you so much for all the support.
I'll probably take a minute or less in lieu of time, but I just want to emphasize the partnership with the promotoras and the testing sites and how valuable that work is. Having the promotoras going to the neighborhoods prior to a testing site, promoting the events, the high energy and the credible members that they are to our community on testing day, dealing with the applications, directing traffic, putting signs out, is a tremendous help to have the promotoras working on the testing sites and every other aspects that they do. And I just want to emphasize the value of partnership. This is really a public-private partnership with the county, with HHS, with LHI, among all of us in the nonprofit community. Partnerships are powerful, and we are seeing the results. So thank you for all your support. And I know Norma is the expert of the promotoras, but I just wanted to say how wonderful the promotores are at the testing site and the valuable support that they contribute.
Thank you, Agnes, and we're actually going to move on to Norma next.
Thank you, Michelle, and thank you, Agnes. Good morning, everyone. The first thing that I have to say is thank you so much to all of you who made this initiative happen. Now, all of us have an idea how much it has helped our community. And I am leading an amazing group of 76 health promoters, and I'm so honored by their dedication to serve our community. I feel so proud to lead them because, as you know, it's not easy going outside, especially in this time, not just because of the pandemic, but also because the weather changed from one day to another. The health promoters have faced rainstorms and cold weather, but it did not stop them from going out and reaching our community to provide COVID-19 prevention education, promote COVID testing, make referrals, plus support all the clinics, plus support all the clinics during the testing event. In November, 73 health promoters invaded the county of Montgomery and reached 42,469 MOCO residents. They provide education to 22,675 people, and they made referrals to 15,686. So these referrals was for COVID-19 testing, 8,543, for the navigators team, 563, to food distribution, 1,516, to the health hotline, 4,337, for the clinical follow-up, 345, and to other services, 385. So as you can see, our goals have been exceeded since the first month of outreach, and every month we have overcome. So, and we haven't finished yet. So we continue working this month with the same enthusiasm and passion to serve our community.
Thank you so much, Norma. It's super impressive to see the numbers and the dedication of the promotoras. I'll be brief as well, talking about the health hotline. I know you guys get regularly our reports. Thank you to this program, we've been able to expand not only the hours of operation, but also the capacity of the hotline. In comparison to the same time period the year before, we're seeing a 500% increase in the volume of calls. And so that, I think, just echoes what you've heard from all of the other partners in this program, the great need in the community. And it's no surprise that the leading reasons for people calling the health hotline are information about health insurance, COVID information, COVID testing, and primary care still continues to be at the top, both COVID related and non-COVID related, food assistance, housing assistance, financial assistance, and unemployment. So again, a lot of the same things that others are seeing around the county, and what my colleagues have also already reported is the same as what we're seeing in the health hotline. So once again, thank you for the support of HHS, of the county executive, county council, in putting together this report. The last branch of our program is our communications branch, and it is integral in connecting and promoting all the different branches of this department and all the information we have to distribute. Our communications team put together a complete, well-rounded branding strategy that includes earned media, both television and radio, digital strategies as well with social media. We have a website, some PSAs, which I will finish off showing really quickly. It's a 30-second PSA, but I think it's very well done, and it's exactly what we need. It's catchy, it's informative, and I think it's also just quite fun to see. So let me just bring it up here. And this is the second of our PSAs, and we're about to release our third one. 1 second now, this is getting in the way. Can you see it? Can you hear it?
Yes.
All right, I ended up talking through most of it, but I know we're short on time. If you go to the saludbienestar.org website, you can find it. Also, if you go to the LHI website, it links to all of our services and all of our information for the Por Nuestra Salud y Bienestar program. And I just want to also finish off by thanking the LHI team as well. They have been extremely supportive and really helping all branches of this initiative get underway and keep showing the results that we're showing and supporting our community through this pandemic. So thank you.
Thank you, Dr. LaRue. The woman represented in that graphic looks a lot like my tia Luli. So really, she really does. Dr. Crowell, if you could say some words, please.
Good morning, everyone. This has been an incredible tour de force, and I want to start by simply first saying thank you for all the support and the partnership that both of these initiatives have demonstrated for us in building this out. You know, a quick thank you to the staff of HHS, and I can't call out all the folks that have been involved in this over the last several months, but I want to thank Arlie Wallace from the AAHP and Sonia Mora from the Latino Health Initiatives, as well as Mark Hodge, who has become COVID Central in HHS in many ways, and Dorothy and Rosarian from my staff. Some general things around this. You know, the connection and support has been phenomenal, and while we were sitting here talking about this number this morning, I got a note that just over 2,800 people died yesterday across the country from COVID-19, which is a new single-day record for deaths in COVID. So it's a somber day. Our numbers are dramatically up for testing. Leading into the Thanksgiving holiday, just the county numbers have been numbered well over our traditional numbers of 8,000 or 9,000 a week, well up to 15,000 people tested, which says a lot about our capacity and how much it has grown over the months. And a good bit of that capacity is due to the work of these two initiatives. And so a special thanks to both of them for that work, because they've reached into places that we needed to reach desperately. And they did that in a way that was quick and fast. It has grown because of that work. A couple of things about each of them, if I can, for a second. You know, the African American Health Partnership around this has built something that did not exist in this county. It's our first attempt to really successfully create a network of care that's focused on the social service needs of Black and African Americans, not just for testing, but the other needs as well. And absent a network of providers that have a long history of contracting or working with government or working in a collaborative framework, the AAHP's effort to pull folks together has been marvelous and a labor-intense process. And a piece of that, of course, began with just the process of identifying a fiscal agent to help manage all of that. So a special shout out to the National Center for Children and Families for their work and willingness to step up and partner with AAHP in making that happen. There are a number of partners that I will not name in this group because they're in the reports that you'll get. But you know, the African American Advisory Group, the African Advisory Group, Caribbean American Group, Ethiopian Community have all come together to help make this testing process possible and this service process possible for the African American community. The Black Physician Network, a partnership that they put together, is something that I said all along was something that I thought was special for them. And unique. We do not have that kind of network of support across the Black and African American community, and have not built that in any kind of way. And as COVID showed up, the racial and ethnic social injustices and disparities across the county, this is one of those places where I think that our work has got to focus going forward. The AAHP was able to pull together and has pulled together a partnership and forge some new partnerships that we now have to figure out how we facilitate, not just through COVID, but in the future, to make sure that we are in a position where this doesn't happen again. So that piece of this, turning quickly to the Latino Health Initiative's work. Salud y Bienestar is again a partnership of organizations that have existed and have some depth and some bench, but have not collaborated in quite this way. So they're coming together quickly as organizations and putting together a testing team and a coalition that speaks for itself in terms of the numbers they've produced, and you heard from this morning. That has been absolutely a joy to watch unfold. It has been an essential piece of our testing initiative, and not just the testing initiative, but also the outreach. The uniqueness of hospitals at home is something, is one of the things that I think is a lesson learned for us in how we do remote engagement and remote health. I'm happy to note that the Montgomery Cares clinics are part of that process, and that they will continue and I hope that they will continue some of that work well beyond COVID, and we'll be able to, looking forward to working with them around those issues. Just the volume and the breadth across these programs has been absolutely amazing. Not just the testing, but the follow-up, folks who are positive, the sharing of, the reaching out to folks who are compromised in terms of their health status to make sure they've got what they need and that they know where to go to get tested is important. You will, I think I mentioned earlier, it was mentioned to you earlier, Councilmember Alvarez and other council members in the meeting, that we will be sending over a funding request for appropriation going into the start of the year. We've got two initiatives that have been phenomenal partners in this process, and we're in the middle of a royal mess in terms of testing, right? In terms of the level of the pandemic. So these have to continue, and not just the testing pieces, but the support pieces that they've described and you've heard described today. Beyond that, I think, just to finish up this way, there is a question about what we do around the vaccine, and I know we're in some early conversations around that. And I firmly believe and know that these two initiatives will have to play a role in helping us to manage that vaccine. There are a lot of uncertainties about who and how and where and what and distributions and whens. But one of the things that I know we have to begin now, and so we're working to pull together a group to talk about that, is the communication around vaccination. You heard from AAHP talk about the immunization issues and flu and getting flu vaccines. This piece is going to be even more complicated and more challenging because we've had 6 months of nonsense spewed out about vaccinations, from everything from bleach to ultraviolet light, and we've now got to finally, I think, get a coherent message, a consistent message. But we have historic issues and historic concerns about it in the African American community. We have immigration concerns about that. We have issues about sharing information and technology, and we have an incredible amount of mythology about what a vaccine is, from things from like rewriting your RNA to injecting you with nanites to mind control. All that stuff is floating around out there, and we've got to fix that and correct that. We are several months away, I think, from having broad-scale vaccines available from folks. So our team internally and with working with public health in the state will be identifying key messages that we need to be on point and sharing, but there are all the other messages that we need to tailor specifically to the communities that we're dealing with. And to make that happen, we're going to have the support and engagement of the Minority Health Initiative and programs. And I believe that as the federal government finally gets its act together around the stimulus package, there will be some opportunity to come back to this table talk about what we need to from these initiatives and how we might need to grow them to help support the vaccination process. It is a thing that is going to keep all of us busy and awake for the next 6 months. So thank you for the opportunity to weigh in, and thank you again to the initiatives for all they have done up to this point. And
thank you, Dr. Corral. This is what we're going to do. We're going to go till 12:10, so 20 minutes. We're going to need a follow-up to this discussion, another committee session that we'll do immediately after we come back from recess and make a high priority, because we're not going to get to all the Q&A today. We'll break for 5 minutes to allow the cable to come up, and at 12:15 we'll start the joint committee session with the goal of ending by 1, so we can go to the interviews at 1:30. So just for my colleagues logistically. We have 3 questions lined up. I'll start with Councilmember Rice, followed by Councilmember Navarro, and then Councilmember Glass. Councilmember Rice.
Thank you very much, and I'm going to try and do this very, very quickly. Again, I just want to echo thank you to each and every one of you for all of your work. It's great to come up with ideas. It's great to insist that something get done. It's great to even write a check for it. But to actually make it happen is something absolutely tremendous. And each and every one of you, again, should be incredibly proud. I did want to ask for each of you, and we've already heard rumors surrounding social media about the rise of distrust. The latest I heard from Africa with regards to vaccinations and alleged conspiracies around what these vaccinations may hold. Now that we are, and I agree with Dr. Kroll, just a couple months out, and we need to start transitioning from also doing just the testing to getting ready for vaccinations. What's your plan for how we're going to outreach to our communities of color and let them know that it's safe? Have we thought about doing, and I love the videos that each of you guys have done and the promotions, because that's important, but have we thought about what it means? And this goes to Dr. Kroll as well, in terms of from a Health and Human Services perspective, in terms of showcasing folks who have taken the vaccination and are okay, to make sure that people can see that. Because I think that the testing that we're doing in the community, people see that. And so just as the person who responded to me via social media said, hey, this is really good and people are going to come out because of it. I think if we see the same thing regarding vaccinations, that may help. So is there a plan for what it is that we're going to do to promote folks trusting vaccinations?
So I'll jump into that. I think early stages around this, around how we do that, but absolutely, we talk about at least letting folks see our public officials getting vaccinated, our first responders, Dr. Gales and members of his team getting responded, perhaps members of you all getting vaccinated as well, so that they know that the folks who are saying get vaccinated aren't afraid to take this vaccine. Beyond that, I think there is a need for us, an absolute need for us, for folks to see their next door neighbor getting vaccinated and saying something about that in social media and across all of our media fronts. So there's this clarity that this isn't just a group of folks that are at the top who are getting vaccinated, but folks in the community who are messaging for us. I love the video that Celia Vienstar has done. And so maybe there's an opportunity, I would hope, for Abuela to do a third video to say, hey, look, I'm getting mine. Why don't you get yours? Everything that we have used, we have to bring to bear to dispel the mythology and to demonstrate the effectiveness and the safety of it, and the importance of why we are going to have to collect information and be able to talk to you and have your information on file so that we can match first and second doses. That is probably the biggest thing that worries me about this, is people's willingness to give people information. And I know that's an issue, particularly in the immigrant community. But those are some of the things that I see on the horizon. As I said, we'll pull the group together to try to flesh out all the different ways in which we can encourage and promote and incentivize people getting vaccinated.
Thank you very much.
Can I just say,
please,
one last piece of that, and I just want to make sure that our minority health initiatives, and we actually need to change that name because there's a couple things that aren't necessarily correct about that anymore. But our people of color initiatives, for them, please understand that the support is still there. I don't want to speak for my colleagues, but I know. And that the robust way in which we need to broadcast this to our communities and make sure that we're showcasing for them. So there's marketing, just as you've done with your marketing for your testing capacity and all the other services that go along with that. There will need to be a robust marketing campaign, even larger, I think, than this one, because testing is one thing. Vaccinating is a completely different animal. We know that we have students and children who we fight every single year to make sure we get vaccinated just to attend our schools. And so from that perspective, this is a whole different animal. This is something that, these are vaccinations that have been out for decades, and people have taken them and they've seen that and still don't trust it. So, there's going to be a lot of work for us to do, and just know that we're behind you and ready to work with you both in support financially as well as structurally to make sure that those kinds of things happen. So,
thank you, Councilmember Rice. Councilmember Navarro.
Thank you very much for the presentation, and congratulations on an extraordinary collaboration. I'm just reflecting on the notion that it's absolutely true that these terms and language that does matter. And what we have also learned during this pandemic is that, we are a county that is majority people of color. And therefore, these kinds of initiatives and efforts have to be done in a way that don't perpetuate this notion that we're just addressing, niche areas or niche pockets in our county. And I think everybody has embraced that. So I'm very excited about how this is a paradigm shift, if you will, with regards to how we treat all of these issues and how resources follow so that we can scale up. I mean, that is just so critical. And I think that also with our racial equity and social justice law, aligning all of this is going to make a huge difference in how we conduct the business of government in Montgomery County. So to me, we've been sort of forced to hurry up and do this, but I think it's going to become the way that we actually do business going forward. And for that, I'm really excited. I wanted to also highlight and give a shout out to Rosario Reyes, who on social media is always showing everybody her work as a promotora at all time, doesn't matter the weather, etc. It's just everybody has embraced this in such an extraordinary way. And to see the presentation of the African American Health Program, to see the numbers, the kit, everybody has really put their best foot forward. So for that, I just want to say thank you so much. We are going to be looking at the issue of the resources and the supplemental that we are expecting. I know Mr. Medellino has spoken to me a couple of weeks ago about that. We want to make sure, and I would like to get a sense. I know we ran out of time, so maybe it can be in writing, because there was some conversation. We had received a particular proposal to divert some of the money from these initiatives because they were not going to be able to be spent by the end of December, and perhaps we would miss the deadline for the. I like to understand what exactly is happening so I can have I can make an informed decision about the level of resources that are needed, because when I go out into the community, what the sense I get is that the need is just very, very, very exponential. And when we approved these resources, we all said that we knew this was kind of like a down payment. So when I received this transmittal that there were monies that the initiatives were not able to spend by the end of December, I was a little puzzled. And so I'd like to be able to reconcile that. And if I could get just some information sent to my office. And that way also, I know Ms. McMillan has said that we should be expecting the supplemental sometime soon. I want to make sure also that there isn't a disruption in the provision of these services, because as we said, now with the advent of the vaccine, the communication is going to be key. But I think we also need to make sure that part of that communication explains to our constituents writ large the reasons why these vaccines are safe. What kind of protocols went through, What has those protocols and what has that yield? That's going to be important because our community is very savvy and likes to rely on factual information. And so that's going to be another layer that we're going to have to address as we now get ourselves ready for some kind of a system to do vaccinations. But thank you very much again. And as was already stated, I'm ready to go for us to be able to expand resource-wise. It's something that I set from the very beginning. It was a commitment I made back in the summer when many of you said, wait a minute, is this supposed to go until December? And my response was, let's set this up because we know that this is now going to become that template. And it's also I believe it's also very fiscally responsible because it has data, it shows the result, and it is leveraging so many different aspects versus doing everything piecemeal, which has always been my most favorite thing. Is let's leverage everything and scale up. So this is super exciting. I have, of course, many other questions. I know we're going to have follow-up sessions, and we have a packed day. But thank you, gracias.
Thank you so much, Councilmember Navarro. Councilmember Glass.
Great presentations, everybody. I've been quietly sitting here, or actually I'm standing right now, listening to everybody and wanted to make sure that my colleagues who've helped stand up these programs, had the opportunities to dive a little deeper. And I greatly appreciate my colleagues' work and leadership, and clearly all of you as well. Too many of you are on the screen for me to individually thank you, but thank you. And what I really appreciate about the presentations and about the work that you're doing is the holistic approach. And we helped stand you up and provide the funding for the direct COVID situation that we're in, and then to hear the details about the mental health work and about the domestic violence support, and then clearly the food security work. We all know that they're all interrelated to some degree, but to see what you've been able to do in the last number of months is a tremendous undertaking. And I, from the bottom of my heart, thank you for your leadership and quick action, because that's really what's been needed here. So many of our policies and procedures have had to either change or, quite frankly, be broken because we've realized that the systems we've had for decades did not meet the times that we're in. So thank you for your nimbleness and your agility to share with us, the number of emails that I've gotten from organizations saying, you got to fast track this in DPS, or you got to get DHHS to do something differently, because we had to, and we will continue needing to do so. So from all of your different perches, not only with these programs, but from your other jobs and your other boards and your other communities, because I know the concentric circles are too large to name, keep talking to us. Talk to me, talk to all of my colleagues, and tell us, outside of this scope, how else we can improve our functionality here so that we can continue doing the good work in the timeliness that it demands. Councilmember Rice asked the question that I had written down in the presentations, knowing that there's a disconnect, knowing that there's a lot of false information. There are other terminologies that we could use, but we'll say false information right now out there. And I'm glad that we're thinking about how to combat that. And I saw in the budget, or in the budgets, I think it was for the African American outreach, the outreach programs and the marketing and communication, and hopefully those will be used to help direct people to why they need to get tested. And to participate in these programs. And then I'll just close in saying, I love the Black Physician Partnership concept, really cool. And, we know, I'm stating the obvious, but we know that, we need more Black and brown teachers in our schools, and it only makes sense that we need more Black and brown physicians taking care of us. Absolutely. And so tremendous good stuff here. Look forward to the continuing conversation, and let's continue this dialogue, because whenever you see roadblocks, let us know so that we can help you all do the good work that you're doing to keep our residents healthy and safe. Thank you all.
Thank you, Councilmember Glass. We've been joined by Councilmember Reamer, who has a quick question regarding vaccine rollout. And so go ahead, Councilmember Reamer. And we got to finish in 5 minutes to get to the next thing.
Thank you. I just had a quick question. First of all, join my colleagues in all of the appreciation. I have seen that the federal vaccination plan requires a data sharing agreement with states that includes information that has to be collected from individuals getting vaccinated, such as social security number, driver's license number. I think Dr. Crowell may have been alluding to that issue, but it is really a concern if our undocumented community, I think most of all, believes that it has to provide information in order to get vaccinated that could then become used, to the disadvantage of the person getting vaccinated. So I know that other states are fighting back on that point. I wanted to find out if there's anything in motion, and I think we ought to have a county letter that takes strong opposition to that and press the state to develop a framework that does not require providing confidential, providing information that would be problematic from that perspective. So I just wanted to ask about that issue and see what we could get moving.
I don't know specifically what the state is working on this now. I am aware of the issue, and yes, absolutely. I think it poses a problem for the folks, some of the very folks that we absolutely need to get vaccinated. There is a need for some data pre and post to be able to identify somebody in some way that's unique. And I know the federal government kind of always defaults to social security number information, but that is likely, very likely to shift as we get to states and as the states push back on the feds around what we have to collect for this. So stay tuned, but yes, we will come up with, I no doubt we will come up with a different way of doing it.
Okay, well, if you could please report back to us. I mean, I think we ought to send a county letter to the federal HHS opposing, a framework that's problematic for us and requesting an alternative arrangement, and send the same to the state and call on them to develop such a framework. And meanwhile, if you could please let us know what you can find out about what the state might be doing. If there's good news to report, great. If it has not yet risen to their level of attention, then we ought to really...
I'll do that and try to track back with you tomorrow during the council briefing if I can, and if not, as soon as we can thereafter.
Thank you, Dr. Crow.
Noted. So, and a very good point. So in the 2 minutes we have left, I just want to say a few things to wrap us up. One, I'm beaming with pride right now. I'm so proud of our two communities and the incredible collaboration and coalition, and the strength and the passion and the energy and the strategy is so impressive and does present, I think, a model for the entire country, frankly, on how to address these very complex and growing issues. And I think gives us a fighting chance to address some of those core public health issues that existed prior to the pandemic. And so as a follow-up session, what I'd like to suggest is that we talk about some of those policy areas, things like telemedicine and telehealth, the connection that we have among our Black physicians, which needs to be expanded to our dental practices and some of those other medical practices. And I'm looking at Dr. Rice. I'm giving you a promotion there, Craig. And so I think that there's so much here. We are going to be working with the executive branch in a public health summit sometime this spring. I'm not giving a date yet because we're all overwhelmed at the moment. But I envision both our Latino Health Initiative and African American Health Program playing a prominent and important role in the development of that summit, so we can apply the lessons learned, we can apply the best practices we have established, that in addition to the enhancement of funding and the cohesion of funding, we look at some of those policy areas. And frankly, we have to do this regionally. It can't just be a Montgomery County effort. We are going to have to enlist a partnership, and I'm on the, as well as Councilmember Glass and Rice, we represent the council on the Council of Governments Health and Human Services Steering Committee, and they are having these conversations, and we're actually going to be presenting to COG what we're doing here sometime this spring, because they want to hear more about what we have going on here in Montgomery County. So a lot more to come. Phenomenal discussion. Thank you all so much. I wish I could tell you to take some time off, but I know you got to keep working, and you got to keep working hard. But muchas gracias to all of you. Truly, you are so inspirational.
Hey,
what we are going to do? Oh,
Gabe, could I just make a quick comment?
Yes, please.
I was not able to be in attendance for most of the session. My staff has been here. I've had multiple meetings at the same time, but I just wanted to express my appreciation as well. Recently got a briefing on the work that AAHP is doing. Councilmember Rice, I'm sure, mentioned we went to one of the great testing sites. Dr. Kroll and I got tested. Still waiting for those results, Dr. Kroll, by the way. But really excited about this partnership on both sides. And I think it's just doing great work. The COVID kits are amazing. The Black Doctors Network's amazing. The work that the Salute Initiative is doing is amazing. So I just wanted to say I'm very excited, look forward to the follow-up, and appreciate everyone's work. Thank you, Chair Alvarez. Vice President Alvarez.
Thank you, Councilmember Juando. So what we're going to do now is, my colleagues, please stay on, but go ahead and turn your cameras off. We're going to take a 5-minute break so that Cable can catch up, and then we'll be given the cue when we're going to start the next session, which will actually be, it's a joint committee session, but it will be chaired by my colleague, Councilmember Rice, the chair of our Education and Culture Committee. So thank you all so much.
To drive defensively and not entitled. We're not talking about right away. We're not talking about fault. We're talking about doing what it takes